Good morning, everyone. Thank you for joining us virtually today for our 26th Rosalynn Carter Georgia Mental Health Forum. I'm Eve Bird, the director of the mental health program here at the Carter Center. I want to give a warm welcome again to the 300 that have registered for this forum today and tomorrow. Before we get started, I want to go over some quick housekeeping notes. First, please be sure to double check that your Zoom video is turned off and that you are muted and until it is time to participate in the interactive activities. If you would like subtitles to appear on your screen, please click the More tab on the bottom Zoom bar and select Show Titles. If you have questions for panelists, please post your questions in the chat. Anna Cunningham and Susan Wisnett, members of our mental health program team, will be monitoring the chat box for us. This event is being streamed on the Carter Center website. We will be recording both days and it will be accessible to on the Carter Center website in the week following this event. I want you to please note that we may have, most probably will have, members of the media with us today and tomorrow. Please also know that some of the topics we cover may be sensitive. And for confidential and free emotional support, you can call or text the Georgia Department of Behavioral Health warm line at 866-399-8938, and that will be posted in the chat. Please don't forget that this is a 2-day event, and if you haven't done so already, you will need to register separately for tomorrow's panels. We will also place the link for to register in the chat. We hope that you will share your experiences and thoughts about the forum over these next 2 days on social media using hashtag Georgia Mental Health. Finally, thank you so very much to our donors who are listed on the screen. We so greatly appreciate their support. And now for welcoming remarks from our chairman of the Board of Trustees for the Carter Center, Jason Carter. Welcome, Jason.
Good morning. I'm happy to join Dr. Eve Bird and the Carter Center in welcoming you to the 26th Annual Rosalynn Carter Georgia Mental Health Forum. It is remarkable to see how this annual event has expanded to include more and more people, more diverse stakeholders, all committed to mental health in Georgia. This year in particular, we celebrate a remarkable achievement. As you know, my grandmother started advocating for mental health in Georgia 52 years ago. And the person that she advocated to the hardest and the strongest at the time was the governor, and it was still a heavy lift, even though she was married to him. But today, we saw in our state the passage of the Georgia Mental Health Parity Bill. That bill is a remarkable achievement. My grandmother would always say that insurance parity will do more to eliminate the stigma associated with mental illness than any other policy change. We achieved it this year, and not only is that step a substantively important one, it's a remarkable testament to how far we have come as advocates to see the broad-based support that bill received in the Georgia legislature and across our politics, including at a time when this country seems more divided than ever. A remarkable achievement, and I'm honored to be in the room virtually with all of you who played such an important role in passing that very, very important bill. Thank you for that. This year's forum will focus on mental health among youth on the first day, and then have a session on caregivers on the second day. Both of those topics are close to my grandmother's heart and, of course, crucially important for all of us as we see our children deal with the aftermath of this pandemic and as we understand the burdens that have been placed on caregivers over the years. I know my grandmother remains incredibly grateful to all of you for the hard work that you have done to have a real and lasting impact on people's lives here in Georgia. I hope that you'll find these next 2 days to be valuable, not only asking hard questions, dealing with the hard issues that remain, but also as a time to reconnect, to have this event, to celebrate the successes that we've had. And in our small way, my family appreciates this event and feels like it's an honor to my grandmother for her 52 years of service on this issue. But now the torch is passed. We look forward to the great work that all of you will be doing. Thanks again.
Thank you so much, Jason, for joining us. Now I'm pleased to introduce our CEO of the Carter Center, Paige Alexander. Paige?
Thank you, Eve, and I'm glad Jason was able to join us as well. So welcome, as he was saying, to the 26th Annual Rosalynn Carter Georgia Mental Health Forum. We are really delighted that you're joining us as we discuss these topics that are truly on everyone's mind now, more than ever, mental health and mental health policy. We're hosting this year's forum virtually again, and I understand attendance was at an all-time high last year with this format, allowing for more of you from across the state to participate. As much as we'd like to do these things in person, this does really open us up to having more people join and hear these conversations, these important conversations. So the pandemic has brought so many changes, and one change that we continue to see is a greater awareness and urgency surrounding mental health and mental health policy. So we know that 2022 is the year of mental health, and it certainly has been the case here in Georgia. As many of you know, for our beloved co-founder, Jason's grandmother and former First Lady, Rosalynn Carter, it's been a year of mental health for more than 50 years. It's our honor to continue the work she has started, and we are grateful for her leadership and often marvel at how ahead of the time she was and still is. So I'm pleased that our mental health forum this year is going to include some important updates about parity and insurance coverage for behavioral health in our state and the progress that Georgia is making to enforce the landmark federal parity legislation that Mrs. Carter helped pass in 2008. So it's my honor to work with all the programs at the Carter Center to advance both our health and our peace work. And although we do have very separate programs, increasingly we're seeing an overlap in all of our work. Healthcare truly is a human right, and mental health is inextricably part of the overall health. So therefore, mental health care is a human right. As the program reflects Mrs. Carter's work and leadership most closely at the Carter Center, the mental health program is a source of pride for all of us. And we really could not do this work without your valuable partnership. So thank you for the work you do. And whether you're a seasoned veteran of behavioral health policy, a future leader in the field, or a new stakeholder taking care of a family member with behavioral health needs, you are welcome here. So we're proud of the circle of behavioral health stakeholders continues to widen because these issues truly do affect us all. And we are so glad to host you over the next 2 days. The Rosalynn Carter Georgia Mental Health Forum is truly a much anticipated event every May, and we appreciate you being with us. So at this point, I'd like to welcome Vice President for Health Programs at the Carter Center, Dr. Kashef Ijaz, to the virtual podium to introduce our esteemed guests for the first panel. Dr. Ijaz joined the Carter Center in 2020 from a storied career at CDC, and I'll let him tell you more about that. Welcome, Dr. Ijaz.
Thank you very much, Paige. So good morning. I'd like to add my own welcome to this year's Rosalynn Carter Georgia Mental Health Forum. As Paige mentioned, before becoming the Vice President for Health Programs at the Carter Center, I was the Principal Deputy Director of the Division of Global Health Protection in the Center for Global Health at the CDC. It therefore gives me great pleasure to introduce this panel that is focusing on the supplement to the February 25th Morbidity and Mortality Weekly Report, Mental Health Surveillance Among Children, United States, 2013 to 2019. The Morbidity and Mortality Weekly Report, or MMWR series, is prepared by the U.S. Centers for Disease Control and Prevention, and it's often called the voice of CDC. The MMWR is the agency's primary vehicle for scientific publication of timely, reliable, authoritative, accurate, objective, and useful public health information and recommendations. Working together with the Substance Abuse and Mental Health Services Administration, or SAMHSA, and the Health Resources and Services Administration, or HRSA, makes these CDC reports so much stronger. the mental health program is pleased to help get the information, the important information included in these reports to diverse stakeholders through this forum. And because this is Georgia Mental Health Forum, we will delve into how Georgia is responding to this information and how we support children's mental health here in our own state. Now I would like to introduce the participants of the panel. Links to their full bios will be dropped in the chat, so I will be brief. It's my great honor and privilege to introduce Dr. Rochelle Walensky, who has been the director of the CDC and the administrator of the Agency for Toxic Substances and Disease Registry since 2020. She is an influential scholar whose pioneering research has helped advance the national and global response to the HIV/AIDS. For the Q&A portion of the panel, Dr. Deb Harry will be joining us. Dr. Harry is the acting principal deputy director, as well as the acting deputy director for the Public Health Service and Implementation Science of CDC. Since 2014, Dr. Harry served as director of the National Center for Injury Prevention and Control at CDC. I will also introduce a couple of the other panelists as well before I turn it over to you, Dr. Walensky. So Ms. Carole Johnson has been the administrator of the Health Resources and Services Administration since 2021. She joined HRSA from the White House COVID-19 response team. She previously served as the commissioner of the New Jersey Department of Human Services. For the Q&A portion of this panel, for her, Dr. Reem Gandour will be joining us. Dr. Gandour is the director of the Division of Epidemiology in the Maternal and Child Health Bureau at the Health Resources and Services Administration. Then we also have Dr. Michael King, who is a captain in the Commission Corps of the U.S. Public Health Services and is the acting director of the Center for Behavioral Health Statistics and Quality within SAMHSA and SAMHSA Region 4 Administrator. He joined SAMHSA in 2019. He's a social worker and epidemiologist who has served at the intersection of behavioral and public health for over 15 years. Our Georgia panelists will include Dr. Erica Fiener Sitkoff, the Executive Director of Voices for Georgia's Children, and Michael Waller, the Executive Director of the Georgia's Appleseed Center for Law and Justice. At this time, I would like to invite Dr. Eve Bird, who will be the moderator for this panel, to go ahead and take charge. Thank you very much.
Great. Thank you, Dr. Ijaz, for introducing our distinguished guests, and welcome to you all. Again, links to bios will be dropped in the chat for everyone. So as you know, and we'll see from a photo, the Carter Center has a history of working with CDC to disseminate the MMWR's finding and key reports at our annual Georgia Mental Health Forum. Dr. Colleen Boyle of the CDC presented Mrs. Carter with a framed copy of the MMWR that was featured during the 2016 Georgia Mental Health Forum. We are very honored to have you all here today and for the opportunity to learn about the importance of this report and what we will need to do at the federal, state, and local levels to address the mental health of children. So again, thank you for joining us. It is quite an honor, I can't say enough, to have you all participating in the Georgia Mental Health Forum today. We'll start by posing a question we would like to hear from each of you. That is, how did your agency contribute to this report? And highlight for us a few of the findings or statistics that are particularly relevant to your agency, if you would. And Dr. Walensky, I'd like to start with you if you're okay with that.
Happy to. Good morning, everyone. Good morning, Dr. Bird, and my many thanks to the Carter Center for bringing us together on this critically important topic. I think everyone listening today understands that mental health is not a simple concept or one that, in fact, that's easily measured. Many federal systems collect data on various indicators of children's mental health, particularly mental disorders, but there's no comprehensive surveillance system for children's mental health and no singular indicator that can be used to define the mental health of children or to identify the overall number of children with mental health disorders. Since 2013, we've been working in collaboration with HRSA and with SAMHSA and the National Institute of Mental Health, and with support from the U.S. Census Bureau to understand the scope and complexity of population-level children's mental health And it was that collaboration that resulted in the report we're discussing today, conceived long before the pandemic. The report provides an overview of 9 data sources from CDC, HRSA, and SAMHSA, and gives national estimates of specific mental disorders, mental health services, and suicide, as well as positive indicators of childhood mental health. We know that these indicators vary greatly depending on where you live, so where possible, we included statewide estimates. I understand that Administrator Johnson and Captain King will share more information on the findings, but there are 2 we found most striking. First is the tragic finding that about 7 in 100,000 children from 10 to 19 years old died by suicide in 2018 and 2019 in the United States. The number of 10 to 19-year-old children lost to suicide is 6.3 per 100,000 in Georgia. Second, we found that one of the most common disorders diagnosed among children from 3 to 17 years old in the United States was attention deficit hyperactivity disorder, or ADHD, affecting more than 1 in 11 children. In Georgia's children in that age group, ADHD was the most common diagnosis, with more than 1 in 8 ever having been diagnosed with ADHD. Mental health and well-being are major indicators of the nation's health overall, and we are deeply connected with health equity. Previous research has documented that mental health among children and adolescents is associated with immediate and long-term physical health and chronic disease, health risk behaviors, social relationships, education, and employment. Children and young adults may experience higher rates of negative mental health outcomes because of social, economic, and environmental inequities rooted in oppression and discrimination and cultural stigma, leading to inequalities in access to care. And certainly we recognize that the mental health of our children is what will determine the mental health of our future. Thank you.
Thank you, Dr. Walensky. Administrator Johnson. Welcome.
Hi, Dr. Bird. Thank you so much, Dr. Bird, and thank you to the Carter Center for hosting this forum. If I could say one comment before speaking to the specific topic, congratulations to you and all of those on the call for the incredible work that you've been doing on mental health parity. It is a priority for the president, it is a priority for Secretary Becerra, it's a priority for all of our work. It is critical that mental health parity be not just words on paper, but action and actually realized in practice. And to the leaders across the organization who've done this work, congratulations to you. I also had the pleasure of and honor of meeting Mrs. Carter when I worked in the Obama White House, and she, as Jason said, asked the tough questions and pushed us very hard on critical mental health issues. And we were able to do some wonderful work together with her. And so again, I'm honored to be here today to continue that conversation and work. As Dr. Walensky said, the MMWR is, as you have said as well, the MMWR is just a critical vehicle for unbiased, fact-based information to get to the public health field. And in both of my tours in the White House, we always looked to the MMWR to help be a catalyst for policy information. So the MMWR would set the stage on what are the facts that we can take policy action on. And so this report that looked across government agencies and really laid out the state of the nation when it comes to children's mental health is a catalyst for us all to really work on the healthcare services and the supports that need to happen to ensure children get the mental health care and services they need. As Dr. Walensky mentioned, the report pulls together data from across agencies. At HRSA, we're the Health Resources and Services Administration. We are organized around equity, providing healthcare services to communities that are historically underserved or in rural areas. And we fund the development of the healthcare workforce to help serve in those communities, and entities like community health centers that provide care to 30 million people across the country in underserved communities. So this is critical to us. This kind of information helps inform the way we put together our budget proposals to Congress. It helps inform the way we think about our boots on the ground and how we help organize how healthcare is delivered, what the next iteration of primary care looks like, how mental health needs to be part of primary care in communities across the country. So we also fund the Title V maternal and child health grants. So we are the major funder to states for their maternal and child health public health work. And through that, we are the funder for the National Survey of Children's Health, which is the largest national state level survey on the health and healthcare needs of children 0 to 17, their families and their communities. And that is an important data point in the roll-up of the data that's in this MMWR. And you'll hear during the Q&A session from Dr. Reem Gandor, who is our just fantastic expert who runs that survey. And so I hope that folks will have the opportunity to ask her questions about the way that we put that data together, the way that we have been able to do longitudinal research in this space. And as Dr. Walensky highlighted, the devastating numbers on children and suicide is the call to action for all of us across the federal government. But underlying that data are the numbers that Dr. Walensky pointed to with respect to anxiety, ADHD, eating disorders. These are all critical issues in and of themselves that we need to address, both in terms of those individual conditions, but also as indicators of what may become more complex mental health conditions going forward. But our national children's survey does have an additional year of data beyond the data reported in aggregate from the MMWR. And so we are able to see in the first year of the pandemic that children diagnosed with anxiety and depression increased by close to 30%, it's 27 to 29%. And that is over, I apologize, let me just be clear, that's between 2016 and 2020. So that's over that 5-year period, but it includes a year of data from the pandemic. Just between 2019 and 2020, we saw a 21% increase in kids identified with behavioral conduct problems, which gives us some early indication of additional challenges going forward. So it's quite clear that we have work to do, and we have work to do together to meet the mental health needs of children and families across the country. And look forward to the conversation today.
Yeah, thank you so much, Captain King, and I turn it over to you.
Thank you so much, and good morning, everyone. It's such a pleasure to be here with all of my colleagues, and I also want to extend warm greetings from our Assistant Secretary, Dr. Miriam Delphin-Rittman. She would be here today, but many, many meetings. Now, SAMHSA's contribution to this report were the data from the National Survey on Drug Use and Health, or NISTA, and it's our nation's primary source for data on behavioral and other health conditions among U.S. households. Specifically, the NISTA is an annual survey of the civilian non-institutionalized population. Now, approximately 67,000 respondents aged 12 or older are interviewed every year, and about 25% of them are adolescents aged 12 to 17. Now, the NISTA results in this report are annual averages based on a combined 2018-2019 data set. And I'm just going to highlight a few of the specific findings that we found really stood out specific to SAMHSA. Now, first, just on the NISTA data alone, an estimated 1 million adolescents met the criteria for past year substance use disorder. And 1/5 of our nation's adolescents had ever experienced a major depressive episode during 2018 and 2019. These really stood out. And these stood out because of the timing of onset of these disorders. What these findings tell us is that early intervention efforts and mental well-being programs need to continue to be implemented at a very young age. Our schools are really our front lines. So many of our SAMHSA programs target youth through outreach, school-based interventions, focusing on areas like crisis, educating parents on their children's mental health, etc. Now, a second area that stood out, and this was already mentioned by my colleagues, but this report confirmed that suicide remains a significant issue for our youth. And although NISTA didn't include adolescent suicide until 2020, so those data have been released, other CDC data sources really tell this story. So for example, YRBS showed that 8.9% of those aged 14 to 18 attempted suicide. And Vital Statistics data from 2018 and 2019 showed nearly 6,000 adolescents aged 10 to 19 died by suicide. So we know suicide can be prevented by reducing factors that increase risk, increasing factors that promote resilience, and SAMHSA has several programs that target youth suicide prevention. Now, while all of these specific findings are very interesting and I love my data, to me, the sum is greater than the parts. Taken together, all of these findings are just a good reminder. They underscore the importance of us relying on multiple different data sources from multiple different agencies to ensure that we all really have the best information for decision-making and robust long-term public health strategies. Thank you so much.
Great, thank you. And we are very interested in making sure that we support the efforts of our federal agencies on the ground here in Georgia. And I'd like for us to take a few minutes just to dig in just a little bit deeper. Some of you have shared briefly some of the your agency's work to improve children's mental health, but could you give us a few more examples of that, if you will, dig in a little bit deeper that's currently underway?
I'll start.
Yes,
Thank you,
please
Dr. Bird. Yeah, CDC has been actively working on children's mental health for many years. This report and our work on understanding and defining the mental health crisis in children and youth is actually part of a much larger picture of the work we're doing to promote the health and well-being of our children, their families, and their communities, not our children alone, but the communities surrounding them. As, for example, for over 2 decades, CDC's supported CHADD, Children and Adults with Attention Deficit Hyperactivity Disorder, and the Tourette Association of America to provide evidence-based information and to support individuals, families, educators, healthcare providers and the community as a whole. This work has strengthened capacity among healthcare professionals and educators, and these programs have connected families and individuals affected by Tourette syndrome and ADHD to each other for support within the community. One family member, after participating in a Tourette program, said, "It feels so good to know we're not alone in this journey." And I think that that's so much of what we do to bring communities together. As I noted earlier, one of the worrying trends we're seeing in this report is the staggering number of children who are attempting suicide, just mentioned. Youth suicide is a complex problem that requires a comprehensive approach to prevention. CDC is leading a public health approach to suicide prevention that uses data to track and monitor suicide trends, researches the risk and protective factors of suicide, and then evaluates the best available evidence for suicide prevention, and then disseminates information on what works to states and communities so that they can employ it. To help youth cope with the challenges brought on by the pandemic specifically, we've supported the National Academies of Sciences, Engineering, and Medicine in the development of a series of free online tools in English and Spanish that teach healthy ways to deal with stressful situations. These tools are meant for teens and for parents and children to use together and include short interactive videos and graphic novel-style documents. They're based on cognitive behavioral theory strategies for reducing stress and anxiety, and they include scenarios from children's daily lives that will help them cope with the COVID-19 pandemic and with many other challenges that our youth face today. And CDC's What Works in Schools program funds local educational agencies and provides strategies to increase school connectedness and information on school-based policies and practices to support the LGBTQ students. The program has demonstrated significant impact on health and well-being, and students in schools implementing the approach showed decreases in risk behavior and experienced less violence, including sexual assault. In our funded school districts, both LGBTQ students and heterosexual students in schools that implement LGBTQ supportive policies and practices have less emotional stress and are less likely to have attempted suicide. So we see the impact of these programs that we're implementing. So thank you very much. We have a lot of work going on and still a lot more work to do.
Super helpful. Thank you so much. Administrator Johnson.
Good. Thanks again for the question. And I would say a couple of things. One, we fund direct healthcare services, as I mentioned, through community health centers, through rural, we work closely with rural health clinics across the country. We fund the Ryan White HIV/AIDS program. So we have a footprint in healthcare delivery across the country, organized primarily around primary care, but we're increasingly working to include behavioral health services, mental health services through their footprint, including using health centers to establish school-based health clinics. So we just recently made announcements of $25 million in new awards to create 100 to 125 health centers to work with schools on the establishment of school-based health centers. I know that's a priority of yours. It's a priority of ours. Secretary Becerra and Secretary Cardona from the Department of Education have laid out the imperative of us really working together to address school-based healthcare, including mental health care and school-based services. So we think community health centers are a valuable way because there's an established relationship in the community. And so if children are seen in their schools, in some instances, our health centers also see parents and teachers' aides and teachers in the school setting as well. And so being able to have that continuity with a community-based care site really helps to ensure that children are getting the follow-up and the services that they need. So we're looking forward to continuing that work and building out our school-based health center investments. In addition, we have, because we are the Maternal and Child Health Block Grant Agency, we work closely with states and pediatricians and OBs and gynecologists on ensuring that we're addressing maternal depression, that we're addressing the anxiety and depression that pediatricians are seeing in their offices, and how do we help pediatricians be able to address and manage mental health care needs. And so we have investments in a state-based training program. It's called our Pediatric Mental Health Access Program. We are training pediatricians in communities across the country and identifying and responding to mental health needs of children. But what in the critical part of this program, we're not just leaving them on their own once we train them. We created in states mental health access teleconsultation lines. So a pediatrician can call a team of mental health experts. In many states, that's a psychiatrist and a psychologist, some licensed clinical social workers who can help the pediatrician manage and understand the particulars of the case they're seeing and help ensure that the appropriate follow-up happens. And so what we've seen since we've stood up these programs is that the complexity of the calls that come into the teleconsult line is increasing, which is an indicator to us. It's anecdotal, we don't have the evaluation yet, but an indicator to us of increasing confidence in the pediatrician being able to manage some of the lower complexity cases and using and being able to build out our capacity to help them manage more complex cases. That's not to say that mental health services need to be comprehensively solved for in a pediatrician's office. We need a continuum of care, but we all know that the size of the need is substantial and we need all hands on deck to be able to respond to children's mental health needs. And oftentimes a pediatrician is the trusted source for families. So building out pediatricians' capacity to identify and respond to mental health needs is critical. We currently have awards in 45 states and jurisdictions. We have new funding opportunity that's on the street now to help expand that to additional states and jurisdictions. We're working with Congress to reauthorize the program. So this is just an important part of our strategy to address children's mental health needs. In addition, at HRSA, we are the home of the Bright Futures Preventive Benefit Program, which is the part of the Affordable Care Act that says if clinical experts identify that certain preventive benefits are necessary for children, then health plans ought to cover those preventive benefits without cost sharing. And so through the Bright Futures program, we continually evaluate the needs of children for preventive services. And just this year, in 2022, Bright Futures, the clinical expert consensus was that we needed to update our universal screening guidelines to add suicide risk to the current depression screening category for children 12 to 21. And so that has now been added to the preventive benefit screening list and will therefore need to be covered by health plans beginning in the next health plan calendar year as a no-cost preventive benefit. And we continue to look at where our clinical experts on the Bright Futures work continue to look at where there are opportunities to address the needs of preventive services for children. And I'll just mention two other quick things. One is We run the Maternal and Child Health Home Visiting Program, which is the voluntary program that through federal resources works in states across the country to provide direct in-home supports to new parents who welcome either nurses in some instances, social workers in others, trained experts into their home to help with establishing new parenting needs and doing assessments around what families might need. Oftentimes that's mental health support. And that service is available until children are kindergarten ready. And so it is about both the educational readiness of students, but also the health services and social determinants of health needs of families. There's strong evidence for this program really helping to improve educational outcomes over the lifetime. And so it is a critical part of our complement of the way we are helping to address children's mental health needs. And it also is up for reauthorization in Congress this year. And then the final thing I'll just say is that HRSA, we are the agency that receives federal appropriation to support the training of the healthcare workforce. We all know this is a critical need right now. We get considerable appropriations for this, but there is so much need here. So the president's budget for the next fiscal year has a dramatic investment in expanding our training dollars for the mental health workforce. And we think of the mental health workforce not just as the graduate level advanced practice mental health workforce, which we would invest in with these resources, but also those critical community connectors that are part of making mental health services acceptable to families, engaging people in care and treatment. So community health workers, peers, individuals with lived experience who can connect with families and individuals, encourage them to get connected to care, help retain individuals in care. And that is an important part of our work going forward.
Great. As I hear you both talk, I'm reminded of the pyramid that we reference with our school-based behavioral health work, that universal prevention that's available to all in the community, and then some early intervention, but then the services that HRSA directly, and getting those services to the community. And it's a community response that's really needed, just not the providers, but really engaging the full community. And we'll talk more about the community connectors a little later in our session. But Captain King from SAMHSA.
Thank you. And wow, I just have to say, there's so much good stuff going on. And I don't know about the rest of you, but I feel like I should be taking notes. Even while I'm on the panel, I'm like, good Lord, the things that I haven't thought about in years, or maybe that I didn't even know about. So this is just wonderful. And I'll say that, we all know that our young people face just a million challenges these days, particularly as they transition into adulthood. And those are significantly more difficult when they're grappling with any kind of serious mental health issue. So I'm only going to flag 4 things from SAMHSA right now, but I want to start with 2 that target youth mental health in schools specifically. So the first of those is our Project Aware, or Advancing Wellness and Resiliency in Education grants. And these were specifically designed to connect state education agencies with local education agencies, as well as state mental health agencies, to increase the awareness of mental health issues, to train school personnel, to connect youth and their families with needed services. And right now we have about 60 Aware grants all over the country in 4 different cohorts. And these are funded in 40 different states and territories, and several tribes have these grants. I think it's just a really exciting program. And in fact, there's an anecdote where they were with second graders, they were using a ball that had feelings listed all around the ball. And when a second grader would catch the ball, they would have to read the feeling and then say something, a story from their life. And just a simple tool like that with second graders can really lead to some important conversations. And so I just highlight that to begin. Second program is our Disaster Response School-Based Services program. And it's focused on providing treatment, crisis counseling, and other kinds of supports in school-based settings that were impacted by natural disasters. And these were specifically the natural disasters that happened in 2018 and 2019, because we know this just keeps going. So the success of this program has been well documented. In fiscal year 20, we funded 42 of these response grants in 18 different states and 2 territories, and 16 of those were delivered specifically within a school setting. So that was really exciting. Now, a third program that I want to note because of the MMWR findings on suicide is our Garrett Lee Smith Campus Suicide Prevention Program. And many of you are aware of this program. It's been around for a while, but it enhances the mental health services for our college students. So as they get closer to adulthood, and yet we know they still need a lot of support even at that age. In the college setting, they're at risk of suicide, depression, serious mental illness, substance use. It's all there. And trying to get services in that setting can be tricky. So in its current iteration, our program is going to fund up to $2.2 million, including over 100,000 from the American Rescue Plan, which is greatly appreciated, for 3 years to up to 22 grant awards. And so we're continuing to expand our reach into the college setting for this population, which often gets overlooked. Now, lastly, and my colleagues noted that services really can't just appear in schools. They have to go out into the community. So given this MMWR's findings, variation by race, ethnicity, variation by geography, I want to mention our RECAST program. So the RECAST program grants were designed to assist high-risk youth and their families in their communities, specifically communities that have faced trauma or civil unrest or other challenges. And it helps those communities form a plan to deal with that trauma through the implementation of evidence-based violence prevention and community youth engagement programs. Now, we've evaluated this program as well, and in fiscal year 21, this program trained nearly 3,000 clinicians on evidence-based mental health treatment for children, and nearly 17,000 individuals who are outside of our traditional behavioral health workforce were trained in mental health promotion and prevention. So it's very exciting. Some work is continuing, and I'm just so happy to hear of all of the other things that are going on. Thanks.
Great to hear all of these, and thank you for that summary and highlighting many of these programs for us. I'm happy to say many of them are familiar to us here in Georgia. They're alive and well and being implemented. One of the things we constantly are looking at and working with our collaborating partners is how do we scale these and get these to other areas that aren't currently funded. We work very closely with our private philanthropy, and in fact are in a process of putting together a brief, because we've had philanthropy come to us and say, show us what gaps we need to fill that other agencies and federal government, state governments aren't doing, or private insurers. So we look to connect those dots specifically. I want to wind up really quickly here, because in that reference to the scaling and the collaboration of these three agencies working together, and we're going to hear more about our collaborations here in Georgia. You had a crystal ball, like what do you think we need to do better to improve the future of our children, particularly their mental health?
Out like this.
Yeah, maybe I'll just start by echoing the comments from Captain King and say that we have an enormous challenge ahead. We opened with the enormity of the challenge ahead, and it's really inspiring to see all the work that's being done to address these challenges. In addition to the important work that I mentioned, such as school health and suicide prevention, there are two examples that I want to talk about with regard to what we're doing in the future, and one is about one of my favorite topics, which is data. CDC is funding the Public Health Informatics Institute's initiative on using data to improve child and adolescent mental health. States can use the opening playbook to learn about public health's role in children's mental health, including how health departments can form partnerships and use available indicators such as school attendance or school disciplinary actions and school readiness. And they use those indicators to assess children's mental health at the population level. The playbook also includes information and resources on legal considerations related to the collection and use of children's mental health data, and I think that's critically important as well. And through a cooperative agreement with the Association of University Centers on Disabilities, we started the Children's Mental Health Champions program. Now, there are champions identified in 10 states, including Georgia, and in 1 territory. And these individuals have diverse experience working in children's mental health settings, including clinical psychology, behavioral therapy, professional counseling, school counseling, early childhood education, and early childhood special education. The champions work together to share share common program goals, but each has their own approach that best fits the individual communities they serve. So for example, here in Georgia, the Children's Mental Health Champion has, in partnership with state and local leaders, developed a curriculum and a professional learning space for school-based behavioral specialists so that they can better support the mental health of all students, including those students who have developmental disabilities. So as we open with, there's a lot of work to be done, and this report has helped us identify a number of gaps in our understanding, making it clear for the need for more comprehensive, more timely, and more specifically local and community data. But I'll end with gratitude. I'm simply really grateful for the partnership of SAMHSA and HRSA and the publication of this report, and truly we are committed to working together and with you at the Carter Center to improve children's mental health now and for the future. Thank you so much.
Thank you, Dr. Walensky. Administrator Johnson.
Thanks, Dr. Bird. I would echo everything that Dr. Walensky said, but I'd like to circle back to a comment that you made, Dr. Bird, which is the importance of philanthropy, the importance of the community writ large. We are, as we've all just talked about, we all are leveraging what we can, putting our shoulder into everything we can from the federal side. We have incredible partners in the community. But one of the things that I think we're increasingly focused on at HRSA, because we do everything through an equity lens and are so focused on reaching hard to reach underserved communities, and that's particularly a challenge in the mental health community because it's not just getting services there, it's building the trusted messengers to get people connected to care, is capacity building of community-based organizations to be able to do this work. It is challenging work. It is very important that there are local leaders who are part of this work, but it can be hard to do as part of our federal grant requirements if you have to do X or Y, if that's not something that you have capacity to do. It can be hard for some community-based organizations to be competitive in a federal grant environment because if they haven't received federal grants before. And so we're increasingly focused on how we do better to make sure that those individuals or those organizations can come in and that we provide the technical support to help them succeed. But also we would ask for all of our partners to help us in this work because we know how critical community organizations are. And we know that the kind of support and infrastructure they need to be able to be at the table and their voices are absolutely essential at the table. It takes community support, it takes grant support, it takes all the things that we can all do together. And then on a policy side, I will say the president's mental health agenda, particularly focused on kids, focuses on three critical things: improving access to care, connecting individuals to care, improving system capacity, which is a little bit of a wonky way of saying we need to do all the things that we've all talked about. We need to build the workforce. We need to build and support the workforce. We need to build the data sets. We need to build on the data we have and modernize our response and systems. And then three, really thinking about how we holistically and equitably support the social and community environments that support mental health. So really social determinants of mental health. How do we support what it takes to promote health and well-being in communities? And so that is the charge that we are all working on together and working on across HHS under the Secretary's direction through our the Secretary's formed a Behavioral Health Coordinating Council where we all sit around the table and work together on how we can achieve those goals the President's laid out.
Really helpful. Thank you. Captain King, I'll let you wind it up for us.
I'll wind it up. Well, so I love that my colleague mentioned the Behavioral Health Coordinating Council, and we could talk at a 10,000-foot level about how we federal partners are working together on the BHCC or through the Interdepartmental Serious Mental Illness Coordinating Committee or some of these other big efforts that we're doing to really all get moving in the same direction and make sure that we know what each other is doing. But today, I want to share what I believe is really the best evidence of our support for children's mental health. And that's where we invest, right? And how we invest in systems and communities specifically. So just a few ways that SAMHSA is doing that, because you've already heard all the wonderful things that's going on. Our Children's Mental Health Initiative stands out because it aims to improve behavioral health outcomes for both children, youth, and their families using a systems of care approach. So essentially, we're investing millions of dollars to build a sustainable, effective infrastructure for these families and these kids so that they can get the services they need. It's been evaluated a couple of times. We've trained nearly 60,000 clinicians. We've done outreach with over nearly 400,000 children and families. I won't go into those details. The second thing I want to highlight, statewide family network program, right? The SFN program, which targets our statewide mental health capacity for family controlled organizations. So meaning these are organizations where families help other families improve their lives. So a lot like our work with community-based organizations, which these are, right? This program, we believe, will serve as a catalyst for transforming mental health systems. It'll strengthen the existing coalitions and create new ones. It'll strengthen relationships among family members, with policymakers, with service providers. So again, looking at that system-wide approach to really building connective tissue. Ultimately, the program is going to fund up to about $1.6 million for 3 years for 13 different grants in its first iteration, and we hope to continue that. Now, finally, SAMHSA has invested $825 million in our community mental health centers, and so that supports 231 community mental health centers across the country. And so it really enables these community mental health centers to address needs more effectively where they are, right? Like the money is given directly to them. And two other programs which are related to that, our Rural Opioid Technical Assistance Program and our Rural EMS Training Programs are continuing as well. Now, I will just say, and just to wrap it really fast, although we know we have billions of dollars in American Rescue Plan funds going through our block grants, the programs that I just listed and that were discussed earlier are really the best evidence of our ongoing commitment to provide prevention, treatment, recovery across the lifespan in the communities where people live. Thank you so much.
Great. Thank you all so much, Dr. Walensky, Administrator Johnson, Captain King. I want to thank you all personally for being with us. You've given us a big chunk of your time today, and we appreciate that. And I know the audience has. We've learned a lot. I also want to thank you all for the work you do. It's been a hard couple of years, continues to be hard work. We know more than ever how important our work is, and I thank you all for giving so much of yourselves and your time. So thank you. If it's okay, I'd like to shift our conversation now to Georgia and how our great state has responded to what many are calling the youth mental health crisis, which we know has been exacerbated by the pandemic. In 2018, the Carter Center, Georgia Appleseed Center for Law and Justice, and Voices for Georgia's Children created the Georgia School-Based Behavioral Health Collaborative. I want to introduce to you my colleagues, Dr. Erica Fenner-Sitkoff, Executive Director of Voices for Georgia's Children, and Mr. Michael Waller, Executive Director of Georgia Appleseed Center for Law and Justice. And because children are either at home or in school for the majority of their time here in Georgia, our vision, along with our many collaborators, is that the school be a venue where mental health is promoted, services are made available as needed, and very similar to the need for nutrition and the provision of a school lunch in Georgia. We have approached this work understanding that this is not the sole responsibility, as I'd mentioned earlier, to schools or providers when there is a crisis, which we are clear we have. All hands are needed on deck. The work needs to be designed and implemented locally. Approaches must be a response to a local community's needs and resources. The School-Based Behavioral Health Collaborative, in partnership with the expertise of our leadership committee, which we formed when we formed this collaborative, key stakeholders, as I mentioned earlier, including philanthropy, and experts such as Georgia's Center for Excellence for Children's Behavioral Health at Georgia State University, and also the Department of Behavioral Health and Developmental Disabilities, providers, peers, and many others have approached this work. We've created tools, and we're excited to say that we will send you an email following this of these tools that have been created by the collaborative. You'll hear more about these. We've aligned partners and resources, and we're providing support at a local level. It's not enough. The work continues. The pandemic has thrown us challenges, but we're committed as ever. At this point, I'd like to ask Erica will also share setting the stage here, Erica and Michael, that something that is different about this MMWR report is that the report also includes data on receipt of mental health services among children and positive indicators of mental health. We heard a little bit about this in the opening remarks, and state level estimates. Michael, I'd like to shift to you first and ask you to share with us your perspective, particularly on the importance of indicators of mental health. This may seem to be a little odd coming from the attorney on the panel and Georgia Appleseed, but would like for you to reflect on that. And then also how Georgia Appleseed is supporting or fostering these positive indicators for the entire population, just not individuals at risk.
Thank you, Eve. First, I do want to say, I'm going to echo that it is a real honor to be here today talking with you and with the other panelists. This is a tremendously important topic, and we're going to talk about why that is in just a second, of course, in addition to some of the reasons that have already been indicated. And so I'm very grateful to be here, and also, those congratulations are due. The mental health parity work that you and so many people on the call, actually the folks listening to, I was scanning the names, have been involved in, and to see these successes is tremendous. And I think it is sort of a dawn of a new era, I hope, and really excited about that. So I just very quickly, I'll explain what for folks on the call. Georgia Appleseed, we're a law center. We do a lot of different things. We see ourselves as walking alongside children to deliver to them some of the things that really are very relevant to the conversation today. So they have a positive school climate and learning environment. They have access to behavioral health support they need, and they have healthy and safe housing. And these are the kinds of determinants, social determinants, and some that can be taught that are directly relevant to the positive mental health indicators that we were talking about. So we do this at Georgia Appleseed through a combination of legal representation, advocating for legal and policy reforms, connecting the child advocacy community as well and government leaders together, and then leveraging the assistance of lawyers. A lot of pro bono support from lawyers in the legal community, which we're always grateful for. So the question, is why are these positive indicators so important? And I'll just list the three that the report specifically talks about, which is emotional well-being, effective regulatory and coping skills, and supportive social relationships. And for me, those are particularly important because there's something you can be proactive about. You don't have to be merely reactive about those things. So those are things that you can foster and you can nurture and you can grow and you can support. In fact, a lot of us as adults will see that as our role in society. That's part of what we are supposed to be doing for children. And particularly from a policy perspective, which for Georgia Appleseed, that's really important to us, you can nurture and promote behaviors and social conditions that may preserve or improve these positive indicators. So the outcomes, right, are going to be profound. You're going to see the mental health and physical health improvement, but as we haven't talked as much about, but a little bit was mentioned earlier, you're going to see improved education outcomes. You're going to see improved opportunities for future employment for children as they go into adulthood. You're going to see reduced criminal legal system involvement, et cetera. And in the short term for parents and for schools, you're going to see fewer discipline challenges in the school setting and fewer disruptions and lower amounts of school mobility and those things that really impact not just that individual child, but the community as a whole. So that to me is why it's so important. And I'll share a quick story about how, individualized interventions can work with policy, because from our perspective and my perspective, those two things should work together. Policy and specific interventions for children should anticipate one another and work together. So you devise your specific intervention with a child, thinking about the policy environment, and the policy environment thinking about the actual realistic specific interventions you can do. So I'll share a very quick story. And that is about Sharice. So Sharice was a client of ours. And Sharice is a child. She's in middle school. She identifies LGBTQ. She was outed by her teacher one day in class, and some real bullying happened after that. She's in foster care. So she has, in the last couple of years, been in several different homes. And one morning, she was at a court hearing where she learned that her mother had told the court that she was no longer in a position to try to reunify with her child. And so Sharice, that was very devastating for Sharice. So she went to the school that day and had a disciplinary incident and got into a fight with another schoolmate. And the school's solution to that proposed solution was to expel the child for a year, expel Sharice for a year. Now, from our perspective, that's catastrophic. That means that Sharice will have to move again, will be destabilizing. She'll have that sense of exile from yet another community. It's these sort of profound implications. So we provide an attorney for her during that disciplinary process. And the result was good in that we got better outcome for her from the disciplinary side. But what's important here is to note that because of that intervention, that lawyer was able to work with the school and get behavioral health supports, other community supports, to get the school to think about how they were acting with, how the adults were interacting with Sharice, and also keep Sharice in school. So she wasn't in fact expelled. She was remained in the school. And her story continues to be written. It's not finished, of course, but there is very good news. In addition to that, she has actually been reunified with her mother. So she's living with her mother again. When her life stabilized some, her mother had a chance too to get some space, and they are living together again. So hopefully, we're all hoping for a happy ending here. But again, these stories continue to be written. The reason why I point that out from a policy perspective is without a big success that I'll talk about here for just a second in Georgia, that outcome just wouldn't have been possible, a big policy success. And so you asked, one of the things that Georgia Appleseed does, and in addition to working with you and with Erica with Voices on school-based behavioral health, positive school environment is a big deal for us. We think it's foundational. It's one of those things where you create that supportive social relationships. You create a space where kids can be taught self-control and resilience, regulatory self-regulation, those things that are positive indicators. So in Georgia, there's a good story here. There's a lot of good news. The state started back in 2005 to study its school environments, the climate that kids were in, whether or not they were supportive or not. And they began a process in 2008, and then Georgia Appleseed began working very closely with the Department of Education and individual schools. And over the last 10 years or 12 years, over 50% of the schools in the state have adopted a positive school climate approach, particularly positive behavioral interventions and supports, PBIS. That's over 1,400 schools. That's hundreds and hundreds of thousands of children. And one of the sort of most impressive results for me about that is looking at the disciplinary results. I mean, the statistics, a direct outcome for children. So in 2005, with a smaller population of students, Georgia expelled. They put out of school for more than 10 days, out of school suspension, 159,000 children that year. There's 159,000 children that year. Over the years, as they have begun implementing, and this program has continued to be successful, you've seen significant reduction. So in 2020, now last year only 38,000. Now, granted, there was a lot there with school closures, but in 2020, only 115,000 children. That is still a lot of kids. That's a ton of kids. But we're talking about 40-something thousand fewer children every year with a larger student population. So that's tens of thousands of children every year who are staying in a school that's more supportive, in a school that actually recognizes who they are as individuals and their individual identities, and where people know their name, know who they are, and support them. And it creates a foundation for them to teach this sort of self-resilience and self-control and those other things that we talked about earlier. So Georgia Appleseed's a partner in that. We provide direct support to the schools. We also do a lot of policy work. So this stuff doesn't happen in a vacuum. You got to have laws passed. In Georgia, we had to have laws passed, and we have to have regulations, and we have to have commitment from agencies and individual school districts. So it's a lot of work that we're really proud to be a part of.
Great, Michael. Yes. And we've got a lot to be proud of, a great foundation. People like to be a part of a winning team. And I think Georgia is on that winning side. With you say 50% have adopted this, but there's still, as you point out, a lot of schools that aren't. DOE has been extraordinarily supportive and engaged in our conversations. But then when schools are really governed at a very local level, we have the challenge and why this work just really needs to continue so that we can bring this and best practices based on the resources that each school system has. Thanks for that overview, and thanks for the work that you all are doing. Erica, can you reflect a bit on the conversation this morning, but then what Georgia has invested in children's services specifically. You're a child psychologist that used to work in schools, and then how that collaboration with advocacy organizations has really grown that capacity.
Absolutely. So, no surprise, I'm going to echo the sentiments that have been shared today. Just am grateful to be here with the other panelists, and every day I'm thankful to do this work with you, Eve, and you, Michael, and the partnership of our organizations, and of course, so many other people on this call. So for those of you that are not familiar with Voices for Georgia's Children, we are Georgia's only and largest comprehensive child policy and advocacy organization. What that means is we work to advance laws, policies, and actions in all areas of child well-being across all age ranges and all 159 counties. And we do that in two main ways. First is conducting research that makes sure that Georgia leaders are equipped with the most up-to-date data on the needs of children and families across our state. And then second is developing advocacy campaigns to enlist others in the actions that we believed the data is telling us that we need to take as a state. And then two are a continual loop together. We lead coalitions, communications campaigns, and then of course also conduct legal analysis and Georgia-based research. So I was inspired consistently throughout the comments and reflections that were made on the panel right before us, because so much incredible work that they spoke to have been manifested in Georgia. And when we look to advocate and determine what are our policy priorities and the change we want to see, we look to the incredible work that is happening in communities across our state, because there is such important work happening there that we need to bring to scale. And I'll reflect on that here this morning. Georgia has made investments in some key access points along the continuum of care across age groups, namely in school-based health and in early childhood. The state agencies have done this in partnership with Voices and other organizations like ours, not only to help determine where those investments will be most impactful, but also to make sure it's aligned with the priorities and needs that the communities say themselves are needed for them. And I'm going to highlight just a few points in each area. First is one of our signature programs here and investments that we've made, and it's our Georgia Apex program. That's our school-based mental health program. In 2015, it was created to bring community mental health provider expertise and capacity where kids are every day, schools. It began with a state-funded pilot of 104 schools for about $7.7 million. And it's prioritized Title I schools as both a way to create access in communities that have been historically underserved, but also increased opportunities for billing Medicaid for sustainability. I'm excited to share that now Apex is in more than 700 schools across the state, with a state-funded investment of nearly $25 million annually. A few years ago, the investment was made in the state to expand telemedicine capability for all Apex providers, which at the time, this was pre-pandemic, we had no idea how critical that would be, but it was a priority that advocates pushed for to help remove transportation barriers. Well, of course, that proved to be critical during the pandemic and allowed those programs to continue to reach hundreds of thousands of kids across the state when schools were forced to close their buildings and go virtual. The state has also invested in training school personnel in a suite of trauma and mental health offerings. In just 2 years, nearly 30,000 school personnel have been trained in trauma awareness, mental health first aid, and that includes everyone that interacts with kids, teachers to bus drivers to those that work in the cafeteria, because we know that one trusted adult that can be life-changing for a young person could be found anywhere. And we wanted to make sure all people, all adults are equipped with that information. There's also support for billing services in schools to ensure sustainability of this investment. And what analysis tells us that the majority of providers, Project Apex providers, which is 70%, bill for the majority of their services. That's a critical point to the sustainability of those programs, and also freeing up some of that state investment and federal investment that was talked about earlier can reach that tier 1 or level 1 universal and tier 2 supports. That program is also looking forward to being a training ground for future clinicians. And the state is working to develop partnerships with clinical graduate programs to place students and use our school-based mental health program to grow the workforce. The comprehensive school-based health centers that were mentioned earlier, we have the guru of school-based mental health, comprehensive school-based health centers here in Georgia, Dr. Vita Johnson, and it started 20 years ago, but in the last 5 years has really exponentially increased. We now have 90 comprehensive school-based health centers across the state of Georgia, with more than 80% of them providing behavioral health services. And Georgia has also used some of the federal relief funding for the pandemic that came into our state to start an additional 12 school-based health centers. We're also growing peer-led support, which is a major priority. We have about 100 schools participating in the evidence-based youth-led suicide prevention program, Sources of Strength. We're not stopping at school districts in the typical school day. We are also looking to after-school and summer programs. Out-of-school time enrichment, after-school and summer programs are such an important piece of our educational ecosystem, not only in addressing academic enrichment and achievement, but in providing mental wellness. We've got, the state has invested the Georgia Statewide After School Network in creating toolkits to support programs, but also trainings and small group coaching for after school and summer enrichment programs to help support the emotional well-being of youth in their programs. And not just school age, right? Like early childhood, our Department of Early Care and Learning has made significant investments in infant and early childhood mental health. We as advocates have, been asking to start early, and not only in meeting school age children where they are, every day, which is schools, but helping childcare centers support infant and early childhood mental health. We had a study committee a few years ago that looked into this from a policy perspective. And since then, the state has invested in a director to lead this effort, created the Georgia Association for Infant Mental Health, has trained more than 70 clinicians in child parent-centered psychotherapy. We've also just released a billing crosswalk so clinicians and communities across the state know how to bill Medicaid for services, mental health services provided to young children age 6 through birth through age 6. This past year in legislative session, in addition to passing the Mental Health Parity Act, which is a landmark legislation, we also have been at the forefront in the nation in getting new mother support. And we've expanded Medicaid coverage for new moms up to a year post-birth, which we know is going to go a long way in addressing postpartum depression and, of course, children's the well-being of children. When caregivers' health needs are met, we know children are healthier. So looking to touching on some of what Michael just spoke about and the most challenging of situations in order to keeping families intact, family preservation, our state and our Child Abuse Prevention and Neglect Plan, our CANP, has prioritized meeting the mental health needs of caregivers and young people. So with the passage and with children, so with the passage of the Federal Family First Prevention Services Act, and now our CANP really underscoring the importance of meeting the mental health needs of children and families and the tragic consequences when those needs are not met. While that doesn't end with the plan, it certainly does signal the importance that our state is placing, and I look forward to seeing the changes there. Two other quick things I want to mention before I close. We talked about reducing stigma and supporting schools in doing that, and our state has invested in our Free Your Feels campaign, and that's with Voices as well as other key partners, Vox, ATL Communication, Teen Communications, Silence the Shame. It's a campaign that's designed to encourage young people to speak about their feelings fearlessly, for the peers and adults in their lives to listen judgment-free and connect everyone to resources that they need. It's got shareable social media resource toolkits segmented by audience and age, guidelines to become a peer-led community, and the promotion of vital support such as the My GCal texting hotline, teen texting hotline, the Not Okay app that was created by 2 Georgia teens to get immediate services when young people are in crisis, and the upcoming 988 line. And I'm going to end with one parting thought, which is looking forward. We talked a lot about today the importance of data, quantitative data, which is so critical, both leading indicators like school attendance and discipline, as well as self-reported measures on screenings and surveillance, and that is critical. We also know that policies work better when they have been developed with input directly from communities in conjunction with data, that quantitative information that adds such rich context and perspective. We also know how valued lived experiences is in mental health advocacy. And looking forward, our work as advocates and in policy must integrate that lived experience not only into informing the policies, but also informing the research that we conduct that inform the policies. And I'm really proud and honored to share that our state Department of Behavioral Health and Development Disabilities has funded voices to conduct this type of qualitative research. We're going to be using some cutting edge methodology to go beyond relying solely on asking teachers, parents, providers, and young people what they think, but actually training and partnering with teenagers to develop the questions and to facilitate the focus groups themselves. We're partnering with Vox Teen ATL, which is an online platform by and for teens, to gather the data themselves from other youth, with the theory that young people will be more open and honest in talking with their peers. That methodology was co-designed with those Vox teens, drawing upon their lived experience in order to ask, really deeply personal questions about the impact of COVID, cultural challenges, availability of supports, and what we've seen from those initial focus groups that the young people have led themselves with support from adults. The responses have been remarkably candid. And that is the candor we need to ensure the systems of care are built and the policies that we create that truly reach everyone, every single child in each of our communities.
Great. Thank you so much, Erica. And I'm sure people, wow, a lot going on in Georgia. I want to remind all the participants that we will be sending out an email of tools, many of which have been noted here in the discussion. I'm sure there are people that are familiar with some of these, and then there's folks that are attending that are saying, yeah, but it's not in my community. How do we get there? And as we've said earlier, this is really a community approach, and we hope that this will inspire you to learn more about these tools and projects and interventions and become involved in your own communities. We all have a role to play here. At this point, I'd like to welcome back our federal agency leaders to conclude our discussion. 2 new panelists. I want to welcome Dr. Deborah Howry, Acting Principal Deputy Director and Director of the National Center for Injury Prevention and Control at the CDC. Welcome, Dr. Howry. And then Dr. Rem Gindor, Director of the Division of Epidemiology in the Maternal and Child Bureau at HRSA. In concluding out in our next about 10 minutes or so, I'd like for our panelists to try and pull some of this information together for our participants. Where do we need to focus? Where do we need to go? And how can we collaborate? What opportunities are there for us to collaborate with our federal partners, our state partners, our local partners?
Eve?
Yes?
You've forgotten Captain King.
Oh, and Dr. King is Dr. King. No, I didn't forget Dr. King. I saw his face on there. I'm sorry. I was, Michael, I apologize for not introducing you again. So sorry. All right. So again, let's pull some of this together for our participants, focus on what we need to look forward to improve the future of our children, and how can we're our focus, but how can we work together? Dr. Lowry, can I begin with you, please?
Sure, and good morning, all. I think the Surgeon General did a really great job with the report, really highlighting how we all have a role to play and the different sectors that are really needed. I believe there were 11 different sectors that have been highlighted in there. And I agree, we can't do this alone. We have got to do this together. And so one way to, I'd say, partner with federal experts is to get involved in already existing partnership efforts. There's no need to duplicate, or be redundant. And so one example is CDC experts are serving on Georgia's interagency directors team under the Department of Behavioral Health. And so that really allows us to help inform and be informed by what's going on the ground. Certainly funding announcements, I think, are always helpful, and our comprehensive suicide prevention program allows communities to really look at who's at risk, how do you develop comprehensive solutions. We have many resources and tools. I know that Dr. Walensky mentioned the tools for supporting emotional well-being in children and youth. I used that with my own child during the pandemic to go through some coping and good stressor skills. And then certainly I would say the last thing would be just around, intensive efforts and technical assistance. States are welcome to participate in things like the youth risk behavior surveillance system so that we can help inform data. We have the Essentials for Childhood framework that has strategies on how you promote these relationships and environments that help create neighborhoods and communities. And then we're known as being disease detectives, but we actually do these epi-aids also on other issues like suicide. And we've done 3 on school systems since I've been at CDC to really look at any school systems that are reporting upticks and how we can work with schools and communities to address that.
Wonderful, thank you. Dr. Gander, can you add? Thank you for being with us.
Thank you for the opportunity to be here. And I have to say, as a survey director, this is the whole reason why we do the work. This is why we field these surveys. We want the data to inform critical conversations exactly like this. And I can also speak for the National Survey of Children's Health. This is the reason why we continue to prioritize the collection of state representative data. We want folks like all of you in Georgia, no matter where you're sitting in the country, to be able to use the indicators to really think through, okay, where are kids, where are families sitting in our state, and what can we do about it? So thank you, first and foremost, for all the work that you're doing. I think there are a couple of different ways that sort of partnerships and collaborations can occur, especially with federal entities. So data and research are my wheelhouse, but I'll focus on a couple of others. The first is that there are a lot of entities at the state level that receive joint funding from either HRSA or from SAMHSA or from CDC. And if those entities have a chance to work together, I mean, we can also do a better job at the federal level, but if the state folks have an opportunity to partner and to make the best use of those dollars to support children's mental health, that's one big opportunity. So couple of ideas there. You could have a statewide children's mental health task force that's really sort of coordinating and identifying where the gaps are in either service delivery or screening or what have you. You could have increasing work that increases delivery of the Medicaid EPSDT services. So there's a lot of different ways that we can, I think, capitalize on shared funding priorities. I also know that obviously the Secretary Becerra is going to be having a listening tour on mental health. That's really an opportunity to hear from providers and community members, and that's going to be going on around the country. And then finally, I will say, kind of pulling from some of the data that we didn't talk about today, but is featured in the MMWR report, we also know that in addition to the positive indicators of well-being, there's also measures of family well-being, and sort of community level factors that may or may not be working in sort of children's favor, so to speak. So just pulling from the national survey, we know that between 2016 and 2020, there was 11% decline in parents reporting that they felt like they could cope with the demands of parenting, and a 5% decline in parents' own self-assessment of their mental health. We also know that there was a decline in preventive visits, not surprising given COVID, but these are the kinds of things that when you stack them up, they really can contribute to kind of an adverse impact on kids' mental health.
Erica or Michael, Dr. Gander spoke a lot about data and surveys. I know in our collaborative, we've talked about the importance of that. You've touched a little bit on this, Erica, in your remarks. I don't know if you want to reflect on that or collaboration with our federal partners around data. We often feel in our collaborative, we have our nose to the grindstone implementing, and are we pulling from the right data, collecting the right data, that kind of thing to advance the work as we make sure that things are implemented.
Yeah, happy to. And I'm sure Michael will have important pieces to add too. Underscoring the importance of that cross-agency collaboration and sharing funding and working together. One of the other, an additional piece of the Mental Health Parity Act that was just passed that was really exciting. In addition, it just really being a message bill about, like, can you imagine if the Georgia State Capitol, the thing that was most talked about this session was mental health? Like that's a big deal in and of itself. But the other thing that it did, particularly in the child and adolescent section, because the bill had different sections, and that part, it spoke a lot about this cross-agency collaboration, creating the match program that is a place where communities can go to get all the agencies around the table to come and support, and then take those lessons learned from those individual cases and create some systemic change about how they work together. It talked about sharing data and information, of how hard that is, and all the acronyms that we say are preventing us from sharing data, like FERPA and HIPAA. But like, how can we make sure that we safely share data that can create better systems for families? Case management is a big, we keep hitting a ceiling with how to effectively case manage and support families and navigating the system, because we don't have a great way to share data and funding, from that perspective. And when we, a few years ago, Voices embarked on creating like a animation of how to access mental health services. And it came down to like, who's paying for it? And how do we sort of flip that script? How do we change the conversation to say, well, there's no wrong door. There's multiple agencies you can go to, because on the back end, we're all working together to share funding. So I think there's some great potential coming out of the implementation of that legislation to better share data and better, braid and blend funding.
Yeah. Thanks, Erica. And Michael, I want to give you a chance to respond. I'm conscious of time because I'm going to do it to Captain King again. I want to hear from SAMHSA and have him wind up. But Michael, your thoughts.
So there are two things, and really just emphasizing some of what Erica said, but one emphasis on local data. A lot of this work is essentially local. I mean, it happens at the most local level possible. And in Georgia in particular, our schools, if you think of children mostly being at home and at school, our schools are often, and increasingly so, and we're advocating for this, being the place of delivery for services and interventions. So we need the most localized data possible, because it is the local policy folks, that means the school principals and superintendents and school boards and others, who are making the decisions, and they need the best data possible. So I would say it's great to have state level data, it's wonderful, but it's so important when possible to have as localized a data set as we can get. That's the first thing. The second thing I would say would be really helpful, just thinking about my own organization, is partnering with federal agencies, not just on with grants and those sorts of things, that's important, but also with training, reaching out to nonprofits and saying, we have data scientists here in our agency, and they could spend 5 hours with your team. We had and you could learn, like, what can you do with data? What does data mean? How do you analyze the data? So that kind of partnership, which we do a lot of that kind of pro bono work, and that delivers to both sides. You know, you develop relationships, you learn a lot that way, and then you're better preparing folks in Georgia to use the data that you send out.
Super positive, out of the box. Yeah. Captain King.
So
reflections from SAMHSA.
So recognizing we're really short on time, but I'm going to chime in on just a couple of these themes that I'm hearing. So the idea that you know, we need local data and we need local response, and that these really need, the solutions we come up with need to reflect the communities where the people live, where the data are coming from, right? The solution can't be something separate from the place where the data came from. So we all recognize that something that works in an urban setting isn't going to work in a rural setting. And so we have to understand that, you know, like telemed doesn't look the same all over the place. So data about it isn't necessarily going to mean the same thing. But from a SAMHSA perspective, the way we're addressing this is, well, we have 10 regional offices. So my first suggestion is, if you haven't made contact with your SAMHSA regional administrator or SAMHSA regional office lately, then reach out. And I happen to know the one here in Region 4. His name's Michael King. It's me. So michael.king@samhsa.hhs.gov. I hope to hear from every one of you. I may not get back to you really fast, but please reach out to us. That's why we're here, to bridge the gaps between a state, the federal agencies that are involved in whatever the state wants to do, and then the locals. And so we are out in the natural habitat, seeing everybody where they live, work, and play. So that's one thing. Another thing that we've done is establish a national network of technology transfer centers. Now, some of you may think that these are just for SAMHSA grantees. No. In fact, a few years ago, we opened up this technical assistance to everyone. So you can reach out. We have 3 here in Region 4. The only mental health technology transfer center in the nation placed in a school of public health is right here in Atlanta. So at Emory, you can reach out to them. Anyone, the public, the state, whoever, can reach out for assistance at our technology transfer centers. So go ahead and check those out online. Look at the resources. There's a number of free trainings, guidebooks, what have you. Your tax dollars have already paid for this. So these are just a couple of ways that you can, you know, bridge the gap between wherever you are and the feds. I look forward to hearing from you. For the next few months, I'm in the Center for Behavioral Health Statistics and Quality at SAMHSA headquarters. So I have a unique window on our SAMHSA data sources as well. And so reach out to me in that time, and maybe I can hook you up with some good data. But that said, those are my 2 cents.
Really great resources. The Technology Transfer Center through Rollins School of Public Health is a part of our school-based behavioral health collaborative leadership group. But yes, a huge resource to folks across the state. Thank you. We're a bit over, but it was so worth it. I really thank you, Dr. Oury and Dr. Gander, for joining us, for Captain King, my good colleagues, Erica and Michael. I think packed with great information, great discussion. Thank you. So we're going to now take a 15-minute break until our next session starts. Actually, we're going to take a 10-minute break because we're going to honor everybody's time and start back on time at 10:45 if we can. And when you come back, you'll be directly hearing from youth. So stay tuned. Thank you all. Welcome back. The rest of the day is going to be spent hearing from young people themselves. We're going to start with a Respect Institute speaker. And I'd like to introduce my friend and colleague, Joel Slack. Joel, it's always a great pleasure to work with you, and we are so fortunate to have you as a member of our Rosalynn Carter Mental Health Task Force. At this point, I want to turn it over to you to introduce our Respect Institute speaker, Paige Gaines.
Thank you, Eve. It's a pleasure to be here today. The Respect Institute of Georgia is an organization that helps individuals construct and deliver their personal stories of their mental health and substance abuse challenges, and of course, their recovery. And we have over 1,800 graduates from the Respect Institute of Georgia program. And today you get to hear from one of our most prolific speakers, Miss Paige Gaines. Paige is 31 years old. She's a native of Atlanta. She speaks very articulately about her experiences as an adolescent with various challenges and also about her recovery. She's been in her recovery for over 6 years. She's a mental health activist, and she rightfully so has a passion for storytelling. So I'd like to introduce to you Miss Paige Gaines. Paige?
Good morning, everyone. So today I will be sharing with you my story of recovery, and the title of that story is My Steps to Recovery. Growing up, I had a beautiful family, amazing parents, and one brother. We lived in a beautiful brick home, which was always filled with excitement and joy. Besides all of my school and family activities, I spent Saturdays as a star soccer player, always elated in victory. These memories will forever be with me. Another memory that will forever be with me is being only 10 years old when I had my first panic attack. And I would have many more. As they continued traumatizing me, getting through middle school became difficult. Mean girls, silly boys, and the stress of school proved to be too much. At the age of 11, I began slipping into isolation and then depression. These dark days and nights felt endless, leaving me hopeless and frightened of my own mind. I had the typical teenage drama, even in attitude, but I found myself arguing with my mom more often than not. Before I knew what was happening, my mom had sent me to live with my aunt. I recall sitting alone with my feet dangling over the edge of a small bed with 2 small windows behind me. As the sunlight peered through the blinds, I made a decision, a final decision. At the age of 12, I tried to end my own life. When I was returned to my home, it was no longer the happy place I had remembered. And it quickly turned into a nightmare after a relative came to visit and he molested me. This triggered my depressive symptoms and worsened my suicidal ideations. 6 long years of this sexual abuse took a toll on my well-being, mentally, emotionally, spiritually, and physically. Although I endured the unrelenting pain accompanied by depression, I smiled my way through prom, homecoming, and those Friday night football games. But my teenage years are spent filled with silent tears and constant thoughts of death. At 18, I was a college student and I started living a careless drug and alcohol lifestyle. It was certainly not a party like I thought it was. I began to self-medicate in order to cope with feelings of sadness and desperation. At 21, I was a college dropout, consumed with debt and eviction notices. My mood swings and related outbursts were always followed by darkness, which were followed by psychosis. One day, I found myself in a public psych ward. The double doors of the psychiatric ward welcomed me with screaming patients, prickling needles, and a lot of staff gossip. As I shuffled through the dimly lit hall, a male guard awaited me for a strip down. A gown was tossed my way as I stood naked, trembling to cover what was mine. I spoke not a word as they pierced me with needles, leaving my arms bruised. Another male nurse with an aura of joy grabbed my hand with such assurance that I will never forget his simple words. "You are fine, you are special. The hard part is over. You're going to be more than fine." I never saw him again, but he gave me some sense of hope. It is truly amazing how kind words can take the edge off of some of the pain. Moments later, I was taken by ambulance to another hospital, but this one was a private hospital. I remained silent and followed the instructions of the director. As we walked through the long hall, something became very clear to me. I was the only one who looked like me. This made me feel alone, and before any treatment even started, I was doubting if anyone would understand me. I was Black and they were not, and my doubts became a reality. no one seemed to understand that in my culture, the African American culture, emotional issues are strictly dealt with in secrecy, stern talks, and definitely with no acknowledgement of mental illness. We are taught to fight any demons by trusting in the church and engaging in God as a form of treatment. Considering that only a small percentage of credentialed mental health professionals are Black, it is no wonder why I felt out of place. I was never comfortable making casual conversation while my peers chatted as if we were on a lunch break. They were casual and comfortable talking about their psychiatric problems. I was embarrassed and needed to get right with God. On my second day, I met with my psychiatrist. Once again, he was white and I was Black. He was a man, I was a woman. I could not help but wonder how on earth he could relate to my secrets. In my culture, we don't share our secrets with outsiders. And what if my family found out about my secrets because I had told a white psychiatrist rather than my Black minister? And how was a psychiatrist going to help me when my understanding of getting better since childhood was hinged on dropping to my knees and praying? I was skeptical. Therapy or medications, it all seemed so foreign to me. I had learned that sad thoughts were those of the devil. I must say that this psychiatrist worked hard to overcome the cultural barriers. Would it have been more comfortable for me to have a Black psychiatrist? I think yes. But when it is not possible, white mental health professionals should learn the skills to navigate the color barriers. To make a long story short, we discussed my secrets. I began to find relief. I finally had answers as to why my life had turned upside down. I now knew the language to communicate with my family and friends on how to best help me. I now knew the language on how to communicate with friends, again, on how to best help me. We discussed symptoms, intense mood swings, heavy alcohol and drug abuse, suicidal ideation, anxiety, and depression. I was then given a diagnosis of bipolar disorder 1. I defined this diagnosis as one day you are enjoying jumping on the bed and having a good time, elated and free. And then weeks or days later, you find yourself hiding under your bed, scared, sad, hopeless, and exhausted. This had been my life. At the age of 23, after finding some understanding and becoming stabilized, I still found myself somewhat unstable in toxic relationships and hypersexual. Although in treatment, my symptoms remained, and while still struggling, one day it all caught up to me. On my 25th birthday, while depressed, I made a decision that would change my life forever. As the night progressed and the drinking increased, I found myself 1 mile from home when I drove my car into a large drainage ditch filled with boulders. As I sat in my car, I asked myself many questions, but one being, how on earth did I get here? Arrested for a DUI, I spent my 25th birthday in jail, sleeping on a steel bench. The following morning when I woke up, I was ready for change. I made a decision to seek recovery. I no longer wanted to be intoxicated. I no longer wanted to live in darkness. So I began with baby steps, daily 5-minute meditation sessions, daily 10-minute reading sessions, 20 minutes of writing. And I continued to exercise my brain and began seeing the benefits of taking care of my mental health and taking it seriously. These small changes made all the difference. In addition to my own efforts, my family was on board, and therapy guided us through these difficult times. We used coping skills and correct language to communicate symptoms and steps to recovery, my steps to recovery. As I grew, my recovery became a reality, and I was living a life some people said I might never have. I rebuilt my support system around me with people who looked like me. You must understand, I needed doctors who were culturally competent. I needed them to grasp the challenge of educating not just me, but my family as well. And my family was Black too. In the following months, I again was transferred to a new psychiatrist. Unbeknownst to me, he was Black. I will never forget our conversation and the intense approach he took while educating me on the process of medication. I was at once skeptical for obvious reasons, one being a conversation I had with my mom. She agreed on me getting help while in the same breath saying, do not let them put you on any medication because we do not do that. We, in this case, is the Black community. Remember when I said I was told to pray? I was always being told to turn my worries and struggles over to the Lord. As the years passed and with my newly built support system in my corner, I was guided through the many stages of recovery. 1 year from the beginning of my recovery, I had overcome obstacles I once considered impossible. I purchased my first car. I moved into my own place. I became a certified peer specialist and held a 9-to-5 job. I even received a phone call from the University of Arkansas asking me to tell my story to a group of teens living with mental health challenges. Wow, look at what recovery can do. Today, I am a certified peer specialist, a college graduate, and a business owner. I am the founder and CEO of 911 St. Jane, an organization geared toward providing the Black and Brown community with resources and a place to share their own story. I continue my work in the community as an advocate. Through transparency, I have been able to educate and support those who look like me and share similar challenges. In addition to advocacy, I provide mental health education to teachers, law enforcement, social workers, and others in the community. As I think about my past accomplishments, my list of goals continues to grow. I wish to develop a curriculum for peers and parents to assist them in the recovery process. And I would also like to travel the world to share hope and recovery to those in need. To my peers, I say, keep going. Recovery is possible and rewarding. Go for your dreams, because if you can dream it, you can do it. To the mental health professionals, I say thank you for inviting me to share my story with you. Listening to stories of recovery will give you more insight. Will give you more insight into what it takes to build a relationship with us. Whether we are Black or white, our goal should always be to listen to each other and learn from each other. Thank you so much for listening to my story.
Paige, we are so honored to have you with us here today. Thank you so much for grounding our work during the Georgia Mental Health Forum with your story and the reality of so many others' stories. You are such an inspiration. I have a loss of words. Thank you so much for being here.
Thank you for having me.
Thank you, Joel. I now would like to introduce Carter Center Mental Health Program colleague, Chris Johnson, the Director of Communications for the Georgia Mental Health Consumer Network, to reflect on what many of us have been calling the year of mental health. Chris.
Good morning. My camera says it is on, but can you see me?
No, we don't.
No, you don't. Okay, let me turn it off and turn it back on. But I will go ahead and get started one way or the other because our time is clocking in on us, right? Okay, it looks like it is just not going to start. So apologies. The camera was working, I promise, just 2 minutes ago. But I am
It's all good, Chris.
Sorry?
Go ahead.
Okay, thank you.
I'm sorry for the frustration. The camera's actually not covered, but my name is Chris Johnson, and I'm a person in long-term recovery. And what that means for me is that for the past 13 years, my mental health concerns have not prevented me from leading a full, productive, and rewarding life. Today, I'm an active and contributing member of my family, my community, and my workplace. I am honored and humbled to be here today to
welcome you all to the 26th Annual Rosalynn Carter Mental Health Forum on behalf of the Georgia Mental Health Consumer Network and the more than 7,000 Georgians in mental health recovery who choose to be a part of our organization. I'm coming to you live today from the beautiful Holiday Inn Express in Augusta, Georgia, where the Georgia Mental Health Consumer Network is hosting an open house at the new Peer Recovery and Respite Center of Augusta. If you are in the Augusta area tomorrow, please join us between 4 and 7 at our fantastic new site here. Information is on our website at gmhcn.org. I just want to start out this morning by saying thank you to everyone here at the Carter Center, working day in and day out, year in and year out, to make the world a healthier, safer, better place. But most especially to those here in the Carter Center's mental health program, and specifically to Eve Bird and Helen Robinson for their leadership on mental health parity in Georgia. In January of this year, when it became clear that something called the Mental Health Parity Act was going to make its way through the legislature and be signed by the governor, lots of people started stepping forward to take these sort of warm-up victory laps and sort of rewriting history in real time. And I spoke to my executive director, Sherry Jenkins Tucker, and we agreed that even in that sublimely, almost perfectly chaotic moment in time, it was worth taking a moment to reach out to Eve and Helen, not just to thank them, but to memorialize the reality that without them and without the work of Mrs. Carter and Patrick Kennedy before and alongside them, we would not have a Mental Health Parity Act in Georgia today. So thank you. Of course, our Mental Health Parity Act in Georgia is far from just a Mental Health Parity Act. As it was originally introduced, House Bill 1013 contained a lot of things that not only did not enhance parity, but that worked against it, that reinforced and even codified stigma. These really regressive pieces of the legislation that would almost certainly have never made it through committee on their own, sailed through, tied to the actual parity bill. And so when I was asked to consider the year of mental health so far, how it has impacted the mental health recovery community, consumers of mental health services in Georgia, I realized that this is actually a perfect place to share with you all a couple of the challenges that we have faced so far, but also how we are moving forward. And the most important step forward that we see is the development of a new group called the Georgia Peer Policy Collective. The Georgia Peer Policy Collective is being established to serve multiple functions necessitated by the scope and scale of the Mental Health Parity Act. A Blue Ribbon panel is being formed to guide the establishment of the group, which will serve in an advisory capacity on state policy matters to the Georgia Mental Health Consumer Network. The group will include at least one representative and or alternate from each of Georgia's 6 regions, and who will actually not be expected to participate in any direct advocacy activities. Their role will be to get knee-deep in Georgia's mental health legislative issues and act as conduits of information back and forth from their communities to those of us who are in direct contact with legislators. The first function we hope the Peer Policy Collective will address is the peer voice in the network's advocacy efforts. The emergence of multiple complex pieces of mental health legislation being considered and frequently amended simultaneously and or in real time has changed what we need to be able to effectively represent the mental health recovery community. For 3 decades, we collected the priorities of our members at our annual conference and could use those effectively, along with other inputs such as listening sessions, to represent the peer perspective in legislative matters. But that's changed now with the volume and complexity of the mental health legislation being designed to completely reinvent most every administrative aspect of behavioral health care in Georgia. The second function we hope the collective will perform is to serve as a clearinghouse for those many people and organizations who came out so strongly in support of mental health this year, identifying themselves as our allies while supporting legislation intended to make it easier to lock us up, put our names in registries police could use while giving us tickets, and all sorts of awful things that most people would guess were planned by my worst enemy, not my ally. When people support legislation that takes away our rights, we don't believe they're our allies. And we believe there should be a core set of principles and values that people identifying themselves as allies or supporters of the mental health recovery community must adhere to. I would hope, for instance, that people who publicly support coercive treatments would find their way onto the not an ally list, which would be public and hopefully contain some rationale or scorecard. The bottom line is being an ally is sort of like being my boyfriend or girlfriend. Saying it doesn't make it true. You don't just get to declare it. I have the choice and I have the voice, but my voice isn't that of Georgia's entire mental health recovery community. That is why it is important that the collective begin its work as soon as possible. A link to the application to become a voting member of the collective will be sent to subscribers to Jim HCN's email newsletter later today, but I'm going to drop it in the chat for you before I leave here. Now, part of my personal experience of the year of mental health was observing how some people caught up in the excitement of the legislative session engaged in some behaviors that were just not okay. Now, it took a minute for me to put my finger on it, what exactly me and some of my colleagues were experiencing. And it came to me that what we were experiencing was bullying. Growing up gay in rural Georgia in the 1970s and 80s, I experienced most every version of bullying imaginable. Life was incredibly difficult. My suicidal ideation began at an age most people would not consider possible. That is why I'm so grateful for all of the work I see being done to support children and their families in Georgia today. There were very few resources available in Dublin, Georgia back then. And I am not certain that because of even higher levels of stigma back then, I would have had access to them. But the difference between possible access to care and no access is enormous. So thank you all for the great work you're doing. And I look forward to seeing you all in person next year.
Chris, thank you so much for your reflections. Your voice is so important, and we value our partnership with Georgia Mental Health Consumer Network and look forward to working with the newly formed collective in the years to come. Thank you again. I'm sorry we couldn't see your smiling face. Next time. Now we'll focus on more from the youth. We recently held a listening session with youth, the Carter Center, in collaboration with MAC. And Voices for Georgia's Children, as was referenced by Dr. Fenner-Sitkoff, is currently engaged in focus groups across the state. We are hearing about the impact of the pandemic on youth, the need for community support, and the importance of talking with peers and trusted adults in their lives. I'd like to share now with you a video from Voices for Georgia's Children, whose executive director you met earlier this morning, and the Multi-Agency Alliance for Children, which I referenced earlier, that's MAC. The interview is Dr. Sarah Vincent, a good colleague and friend of the Carter Center. She's worked with us in Liberia and school-based behavioral health, and she currently chairs the subcommittee on children for the state's Behavioral Health Reform and Innovation Commission. Brandon, can you show us that video, please?
If you were the boss of a school, what would you tell teachers about how they should respond to kids?
Listening is always number one. Adults have to be prepared to listen before they give their opinion on something, because sometimes adults will just cut right to the chase and don't hear what the child is actually feeling inside.
Little kids, they tell you exactly how they feel because they don't know how, they don't know how not to say things.
But then there's like one kid who's really depressed, crying every day in class, like stepping out of class and spending too much time in the bathroom, If there's not resources available for that person, they're gonna feel trapped and like they have no one to go to.
I just think that they need to learn to slow down, and if they see a kid distracted with something, they need to go over and just ask a few questions if they're okay, or if they need to see the nurse or need to go out in the hall and talk for a minute.
Well, I don't think they should just go ahead and yell at the kid, but ask them what's the problem first, because at my school, they love to go ahead and just get on the kid, but they don't really get to the bottom of it.
So what do you think teachers or the other people at school could have done to help you with those symptoms?
Talk to me about what I need to do and what I don't need to do.
So what were they doing instead?
They put me in ISS.
So when an adult doesn't listen to a kid, how does a kid think that adult feels about them?
I think that the kid feels like he or she is invisible or something. Like no one wants to hear what they're saying.
There might be something deeper that's happening that's causing them to act out. So, listen to your kids, I guess is what I'm saying. It helps because knowing someone is listening, it gives you hope.
Thank you, Mac. Thank you, Voices. Thank you, Dr. Vinson, and a special thank you to the youth who agreed to participate in that really powerful video. I can't watch it enough. Now I'd like to turn it over to the moderator for this next discussion with youth. Happy to welcome Shanti Das. Great to see you again, Shanti. Shanti is the founder of Silence the Shame, a mental health education and awareness nonprofit here in Atlanta.
I know she
and
was going
works
to be on
to
that.
eliminate the stigma surrounding mental health. I want to remind you, if you have questions of the panelists, please put them in the chat. Again, Shanti, welcome and thank you. So great to see you again. I'm going to turn it over to you.
Can you hear me?
Can hear you.
Thank you. I bring you greetings from the studios of WSB TV. I actually did a live town hall this morning on KISS 104.1. And so they were gracious enough to allow me to moderate this conversation. Again, my name is Shanti Das. I'm the founder and CEO of Silence the Shame, which is a local nonprofit here in Atlanta, Georgia. We exist to empower and educate communities around mental health and wellness, especially underserved communities. I absolutely am so passionate about this work. So welcome to the Youth Voice Framing Mental Health panel discussion. And I'm so excited to bring up our two incredible panelists. So first up, we have Kayla Renahan, and we're gonna let Kayla introduce herself. Kayla?
Hi everyone, my name is Kayla Renahan. I just recently graduated from the University of Michigan with a degree in public health with an emphasis in community and global health. In the fall time, I'm going to be heading to BU to pursue my Master of Public Health degree. And the mental health issues and topics that I'm most interested in include the intersection between substance use and harm reduction, as well as the mental health of young Asian American Pacific Islanders.
Thank you, Kayla, and thank you so much for your voice and for being here today. Next, we have Adalise Rojas. Welcome, Adalise.
Hi, thank you. Hi, everyone. My name's Adalise. I use she, her pronouns. I graduated from UC Santa Barbara last year in 2021, majoring in political science and English. Kayla and I are both past and former spring 2022 interns for the mental health program at the Carter Center, and I'm really excited to be here.
Thank you again for your voice and your work and your commitment to mental wealth for our youth, Adalise. We really appreciate you being here today. Next, I'd like to read a blurb. The Surgeon General recently released an advisory on protecting youth mental health. A Surgeon General's advisory is a public statement that calls the American people's attention to an urgent public health issue and provides recommendations for how it should be addressed. Advisories are for significant public health challenges that need the nation's immediate awareness and action. So we're going to have a conversation about the Surgeon General's recommendation for action. We want to find out how these recommendations resonate with youth and young adults. So first, I would like to pose my first question to you, Kayla. The advisory states that we all need to recognize that mental health is an essential part of overall health and that people experiencing mental health challenges deserve care, not stigma. Do you think our society is starting to recognize this fact? And what are some ways that we can demonstrate that mental health is no less important than physical health in our actions and in our words?
Yeah, so I think the advisory is a great place to start. As you mentioned, an advisory is only issued when something needs very immediate attention. From a youth or adolescent perspective, I definitely think, especially with COVID-19 and with my generation as a whole, I feel like we've often been compelled to use our voices to highlight mental health as an essential part of health. And with, I guess, my public health background, we're talking a lot about the social determinants of health, or the things where you live, work, and play that affect your health. We are kind of shifting again towards talking about the social determinants of mental health, which I think is very important. And so I definitely think our society is starting to recognize what an issue this is. In terms of stigma, I think we still have a lot of work to do. Adolescents and I were having a conversation earlier this week about how there's kind of a spectrum of stigma, and that some mental health issues may garner more stigma than others, such as substance use. So I think in terms of us as a society demonstrating the importance of mental health, I think on the policy level, parity is extremely important. So covering mental health issues on insurance on par with physical health issues. And that's something that I know the Carter Center champions and I've learned so much about through my internship. And, you know, I think another thing is focusing on prevention before intervention is needed. So really talking about primary care before we're getting to the point where youth and adolescents are needing help. So I guess one thing that comes to the top of my mind is better counseling systems in school. I know personally for me in high school, my counselor was someone you went to when you needed your schedule fixed. So, you know, I've seen great efforts in school systems kind of trying to get school psychologists in rather than just counselors, but I think we have a long way to go. And again, as Chris stated, sharing his story, that being an ally is a really collective effort. It's more than just the title. It's more than saying, oh, I am an ally. And that goes for other youth, that goes for teachers. And like we heard in the video, adults need to be prepared to listen before they speak. Being an ally and offering support is so much more than just saying, I support you. It's really showing with your actions.
I love that. And, you know, I think the stat is it should be, you know, one school psychologist, right, for every 500 students, but not all of our states. And I'm not sure what that statistic is like for the state of Georgia. But to your point, we do need to get more school psychologists within the system. Adelise, did you want to add anything to that briefly?
No, I think Kayla hit it on the nail and she articulated everything very well.
Absolutely. So I'm going to go to your question, Adelise. The advisory calls on us to empower youth and their families to recognize and manage difficult emotions. For youth, this includes building strong relationships with peers and supportive adults, being attentive to the use of social media and technology, and seeking help when needed. In your experience, Adelise, as a college or high school student, how important is the mention rather of social media in this recommendation?
Thank you for that question. I believe that social media definitely is a double-edged sword and can be twofold, especially since the pandemic and the rise of TikTok. There has definitely been more videos that are Eurocentric and showcase very skinny influencers and ideals. And it's very easy for youth, and I know I succumbed to this multiple times, just having the mindless scroll on social media and being exposed to millions of videos can lead to things like body dysmorphia, getting triggered, secondhand trauma, and feeling tied to the phone. I know for myself, I really struggled over the pandemic with my body image and obsessively maintaining what I was eating. And this really developed because I was going on these social medias and TikTok and seeing people's best selves all the time on social media who didn't necessarily look like me. And for me, social media hindered my mental state, and it became easier for me to become obsessive with my body image, especially since I was being exposed to multiple platforms of people. But on the other hand, I don't think that social media should be framed as the defining factor of a person's mental state. I'm not saying that the Surgeon General's report is doing that, but I would advise people to not only focus or only pigeonhole themselves on saying social media is causing youth's mental health to deteriorate and it's the only reason. So it should not be labeled as the sole contributor at all. I was actually in a meeting a couple years ago with mental health advocates, and they were putting on a presentation about youth mental health. And their entire presentation was framed on social media. And that was really discouraging to see as a student. And I had to kind of speak up along with other students in the meeting and say that, hey, outside of social media, there's so many other different factors at play, like background, identity, your access to care, your finances, and your proximity to resources. And so I think it's really important for adults and people outside of the youth circle to understand that, yes, social media does play a big role in mental health, but it shouldn't be the only thing that is talked about. And on the flip side of that, social media can have its own benefits. I think with Instagram, it has been a new platform for advocacy that youth can turn to for education and mental health resources and be able to bond with others who might be going through the same thing. And it really is something that allows them to understand that they are not alone and even make online friends, which is pretty nifty. I know for me, when I was really struggling, I made sure to follow a bunch of mental health accounts, and I made my entire For You page mental health focused. So when I was having a difficult day, I could just go on Instagram, like a couple posts, and just kind of remind myself and ground myself. And for me, even though social media before hindered my mental health, it also became a different way to help expose me to, okay, what does this mean? And what does that mean? How do I calm my anxiety and develop coping skills properly? So I think, again, it really is a double-edged sword.
I agree 100%, Adalise. What a great perspective, right? That we should not just blame social media, right? There are obviously some things about it, with it being that constant highlight reel, right? That desire and will for perfectionism, but some people are also using it in a healthy way. I know for me, I call myself Auntie Shanti. I have a lot of nieces and nephews your age. And during the pandemic, to your point, they were able to find community, if you will, within TikTok, within Instagram. And so I think there is a key there in trying to balance it out and being able to understand like the positives and the negatives for social media. You also talked a little bit about access to care. So I want to throw this question over to Kayla. Another recommendation is to ensure that every child has access to high quality, affordable, and culturally competent mental health care, which is so important, right, in communities of color. What are the barriers, Kayla, to access to care for young people that need to be addressed?
I think one of the big things is within the question itself is this concept of culturally competent care. If you look at statistics, there's really not many providers that are trained to do this. And I know Paige in her talk previously discussed the lack of Black counselors and providers, and that goes for any BIPOC providers or providers who identify as LGBTQ+ and who can identify with that experience. So, I can talk about my own personal experience into my research into AAPI youth mental health and being a proud Filipino woman myself, and that there are barriers to connecting with a counselor who doesn't look like you or who can't share that experience, your lived experience. So when we're talking about discrimination or the AAPI notion of saving face, and that stigma really extends to the entire family, it might be personally hard for me to connect with a provider who has really no idea what is going on. And so I think just like any other public health issue, we really have to view these barriers as intersectional. So again, in the question, high quality, affordable, culturally competent. Research shows that most youth who are at risk for poor mental health are those who occupy multiple marginalized identities. So I think we really need to take a step back and not look at these barriers, such as affordability, as just one barrier. They're kind of all a domino effect. There can be multiple barriers. It's not just one. And oftentimes those, like I said, who are at most at risk are often those who face multiple barriers. So again, I think I'm a really big advocate for cultural competency in the counseling setting, but really any barrier under the sun kind of falls under these social determinants of mental health. So affordability, geography, do you have transportation? And so I think we also really need to talk about agency as a potential barrier. So if I rework back to the Asian American Pacific Islander example, say you have someone who identifies, a youth or adolescent who identifies as AAPI, they may be able to afford therapy, they may be very close to high quality care, but the whole concept of saving face of the whole family, that might be the barrier in and of itself. So I don't think moving forward, we can look at these barriers as individual. Does the individual have agency in the first place to seek care or understand what they are going through?
Thank you so much for your guidance and insight, Kayla. I know the future is bright, certainly with you and Adelise out here on the front lines for our youth again. So thank you for your voice and for the work that you do. I'd like to go back to you, Adelise. The advisory recommends supporting the mental health of children and youth in educational, community, and childcare settings. How important is it to have environments that support mental health and prevention initiatives in school and the spaces where youth spend most of their time?
Very, very important. Again, it's where children spend most of their time. I've had many friends who've had depressive episodes, deaths in the family, overall just very traumatic events, and go straight to school right after or talk to a teacher because they felt they had nowhere else to go. And that is the situation for many, many students out there. I know current Georgia policies include one school psychologist for every 6,390 students. And as you mentioned before, the recommended ratio is 1 to every 500. And Georgia State Medicaid program does not cover school-based mental health services, nor those services via telehealth. And there are no requirements on well-being checks for students. And despite all of that, depression is high amongst children that are living in poverty level households, and many students report seriously attempting suicide in high school. And so if students aren't getting the support that they need at home, and they're not getting the help at school, how do we expect our youth to succeed, especially those who are already at risk? And it's just setting them up for failure at that point. And despite Georgia having an APEX program that creates partnerships between schools and mental health providers, gender-specific school-based resources are lacking in Georgia, especially when we look at communities like young Black girls, even though it's a huge community, right? And so when I worked as an intern for the mental health program with the Carter Center, I did my own personal research on what resources were offered for girls in schools, and there was little to none, especially for young Black girls, which is disheartening. Why? And in fact, research from the AAUW suggests that Black student girls have a higher rate of suicide than their peers, yet no resources are offered to them in Georgia. Why? I think it's important to think about these racial implications and the biases in not offering our most vulnerable groups the resources that they deserve. And instead they get labeled as troubled teens who are being pushed to the margins and being forced to drop out. I actually have an aunt who's a doctor in Georgia, and she confided that she's met so many depressed and anxious teens who don't know what to do and where to get resources. And she found it very difficult to help provide for them and to help find those resources for them. And so doctors are getting the brute front of that as well, and schools aren't providing enough resources. And when I was doing my research, I did find a couple of nonprofit organizations that really did help and partner with schools. One of them was Black Girls Smile, which offers a variety of programs and workshops for schools that focuses on empowering Black girls to embrace themselves and improve their mental wellness, along with a therapy assistant program, which sounds great. And there was also Therapink for Girls, which is a nonprofit in Atlanta that provides weekly conversations about mental health by partnering with Atlanta Public Schools. And they have great missions, and those are great. But where is that within the school? It's just being advocated for outside of that environment instead of within. And so to answer your question and to kind of loop it back, it is very, very important to provide these resources within schools and make sure that our most vulnerable populations are being taken care of.
Thank you. Thank you. So much great information there. And as I mentioned, I'm the founder, and CEO of Silence to Shame. And we're excited that Senator Anderson wrote a resolution for us designating May 1st as Black Children's Mental Health Day in the state of Georgia. So we are going to advocate for more programs. And also our executive director wrote a curriculum for a youth cope clinic that we're doing. We hope to reimagine like what the May Day means, right, in our schools and really create some wellness activities that affect our mental health. So thank you for all of that, Annalise. I want to go back to you, Kayla. Another recommendation is to address the economic and social barriers that contribute to poor mental health for young people, families, and caregivers. Priorities should include reducing child poverty and ensuring access to quality care, healthy food, affordable health care, stable housing, and safe neighborhoods. Describe how you think these other factors affect mental health and well-being of youth.
Yeah, I love this question because I think it really connects to the larger discussion about the social determinants of health, and more specifically, the social determinants of mental health. So many of these priorities that you listed are really institutional level things that need to be changed, that are kind of getting at the root of these mental health issues. So I guess I could take it back to an example with COVID-19. It's often many of these factors combined contributing to a disproportionate burden of illness among certain marginalized populations, including BIPOC communities. So I think we really need to take a look at the intersection of these factors together and how cyclical and how just one of these factors is often coupled with many, or can be, I guess, the domino effect of others. So for example, take a low income student, say when they after school, they have to go to their job. Maybe because of that, they're not getting a good night's sleep. Then they're unable to do their homework. Then they're underperforming in school. They're tired in school. They don't have the time to do extracurricular activities or social activities like quote unquote normal students are able to do, have the privilege to do. So that can really result in these poor mental health outcomes. So just to demonstrate that any one of these factors can start this chain domino effect. And I really want to encourage everyone to think about what can happen when multiple of these factors are at play. So I really think this recommendation of reducing child poverty, ensuring access to quality care, healthy food, affordable healthcare, stable housing, safe neighborhoods, I think it's not just one of those things that is the key. Unfortunately, it does have to be all of them. And I think that's why it's so great in the recommendation, because these are very institutional, structural level things that need to change. And I think finally we're starting to understand mental health at the institutional and structural level. And I think that's kind of the key in addressing this youth mental health crisis and mental health crisis in general.
Thank you, Kayla. All great points. It really is a lot of layers to it, right? And so many things that go into the overall, I guess, contributions, right, of how to make sure our youth have the best mental health care available. Last question to Adalise before we're going to go to and introduce our poll. As a recent graduate, you may like this recommendation to increase timely data collection and research to identify and respond to youth mental health needs more rapidly. We heard about some youth focus groups happening in Georgia earlier. Why is it important to engage directly with young people to understand trends and design solutions? Because you could hear from Auntie Shanti all day, but you all need to hear from one another. Tell us about that, Adalise.
Thank you so much for that. Yeah, sometimes what we think the youth need aren't actually what they need, and that happens very, very often. I acted as a moderator for a youth listening session for at-risk youth, and one thing that they really emphasized was just needing someone to listen to them, and that school staff really needed to better attend to the needs of the students. And one of the participants brought up the idea of an after-school program and creating peer support groups within school hours that could offer them a safe space to engage with others. And in my Californian high school, we did not have, we weren't really big in after-school programs or peer support. So that's not something I would have even really brought to the table at all, even though I graduated only a couple years ago. And so they were really bright and educated and smart about their solutions and knew about what other high schools were doing. And so I think it's really important to include them in the conversation. And some of our youth live in group homes. They're teen parents, have unstable families, and are already in a point in their life where they're feeling overwhelmed with the topic of college coming up. They're thinking about graduating, they're thinking about getting a job, and so many more other stresses that are included. So I think their voice is really imperative, and they're at the center of everything that's going on. And they're at a very difficult point in their times where they're transitioning. And some of the participants also talked about the importance of self-care in their lives, whether that be hygiene, having their sports, socializing, and that became really difficult to do with the pandemic. And I think it really offered new stressors about housing and food and work and being able to support for themselves and the people closest to them and their ability to do well in school. And so there really is humanity in just sitting down and actually talking to youth, no matter what the end goal is, and just understanding what they're dealing with firsthand. Every person's experience is different. My experience is different. Kayla's, anyone you talk to. And so sometimes what they really need and what they really, really kept pushing within that youth listening session was that they just need someone to talk to and hear them out and treat them like their voice matters, which sounds really simple and sounds like, well, yeah, duh. But it can make the world of a difference in understanding what they are going through and how to tackle solutions, actually actively including them in solutions rather than just taking advantage of their voice and being like, oh, checkbox, we talk to youth, that's it, move on. No, continue that conversation, continue those connections, tell them, hey, we were thinking about, doing this, what are your thoughts? How would you like to see this implemented? I think really is just important and imperative and needed. And we cannot do any research about youth without including youth voices, nor youth researchers or assistants. It would be hypocritical.
Oh my gosh. That was incredible. That was amazing. Thank you so much for that. I think everyone on this virtual call needed to hear that. We heard humanity. We heard inclusivity, right? We need to also, as adults, give our youth some grace because they're going through so much and it is so many layers, right? And barriers to care, but we want them to be included and a part of the conversation. So thank you so much. That was awesome and spot on. So now we should find out from those of you that are participating today, how are you planning to take action? Anna, are you there? Who is going to introduce our polls? Anna?
Yeah, yes, hi, I'm
Hi.
here. Brandon, can you put up the poll slide, please? So I'm just gonna ask, we're having a little bit of a technical difficulty, so I'm gonna ask that everyone put into the chat while your answers while I read this out loud. So May is, if everyone didn't know, and May is National Mental Health Awareness Month, and tomorrow is Mental Health Action Day, which is, so we're asking you, which one of these actions will you commit to taking? A, learn more about warning signs of emotional distress and suicide in youth. B, engage a young person you know in supportive dialogue. C, share resources with youth in your community about how to seek mental health supports. D, elevate the voice of youth in your programming and organization. And B, be a good role model for young people by taking care of your own mental health. And we'll just kind of wait as you guys sort of feed in your answers. It looks like there's a lot of people who say all the above. So we can just, in the next couple of minutes, just talk through that.
Okay, can you hear me?
Yes.
All right. So I want to ask you, Adelise and Kayla, do you have any reactions to the poll response? We'll start with you, Kayla.
It's really like awesome to see that so many people are saying, I want to do all of them. I think it's really awesome to see people making a conscious effort and seeing that, again, it might not just be one thing. One thing is a great starting point, but to do all of them is so important. And I think especially if you have kids, or I wish someone maybe would have talked to me. So I think the engaging youth in a supportive conversation, I think that one personally might be at the top for me, because like Adelise was just saying, getting back to the humanity, getting back to the humanness of just having a simple conversation and listening before you speak, truly listening.
Thank you for that. Adelise?
Yeah, I agree with Kayla. I think the top one for me is engaging with youth. I am an older sister to a 12-year-old little gremlin who loves to run around the house. But I think I really want to just show her that it is important to have these mental health conversations, albeit however awkward or difficult they may be. And because I was older, I really didn't have or talk about that, especially since my family was already struggling with putting food on the table and providing for our family. So talking about mental health was out of the question. So I think it really is important to show our youth and those closest to us, our nieces and nephews and people we know, at whatever age they are, no matter how young, to be open and honest about what mental health looks like, what struggling with your mental health also looks like, and being honest.
Yeah, absolutely. I have to share with you all, when I was 7 months old, my father died by suicide. And it was incredibly tough for me once I got to about 5 or 6 years old to understand what had happened. And we didn't talk about it growing up in African-American culture. And so that's why I'm so transparent now with my nieces and nephews and the village of kids, you know, that I look after as Auntie Shanti. It's just so important for them to see me being vulnerable, right? Which gives them permission to open up and share. And so, you know, Kayla, Adolescents, what you all are doing for the young generation, you know, is just amazing. My heart is full. I feel excited about you all leading the charge, particularly for the state of Georgia and on a national level. And I have one final question that I'd like to ask of both of you all. And we've seen so many people in your generation starting to open up, particularly those that are in, you know, the limelight, like a Naomi Osaka, right, or Simone Biles. So the final question to you young queens on this virtual panel today, Youth Voice Framing Mental Health, is do you think that young people today are going to be the generation to finally eliminate stigma against mental health? Kayla, take it away.
I mean, from our conversation, I think we've already kind of seen how youth are engaging to eliminate this stigma. You mentioned Simone Biles and Naomi Osaka, and I think that's an incredible and amazing point to have with the compilation of social media, all these conversations together, and even Adolescents kind of sharing about moderating that kind of youth advisory panel, and her even sharing that maybe those were things, I'm only 22, me and Adolescents are a similar age, that there were things that those children brought up that she would have never brought up, gives me a lot of hope and is very exciting. I think we're really at a crossroads in the point of time that we're seeing this is it. This is the chance, especially with COVID. This is the turning point. And I think even with social media, I've seen so many supportive comments. I've seen people share their recovery stories. And I think we're at a really special time. And I wouldn't be surprised to say if this generation is the generation to eliminate stigma and to really start these conversations, even engaging older generations in these conversations. So I'm really hopeful and really excited. But to answer your question, yes, I do think that this is the generation to eliminate stigma, and I'm very, very, very hopeful.
Thank you, Kayla. I am hopeful as well. And I love your point about also influencing the older generation, right? Because even when you think about that notion of taking care of the whole child, right, in education, if you teach them about mental health in school, but then they go back home and Nana or their grandfather is still not into it and there's so much stigma there, then it's really going to do the child a disservice, right? So we got to be able to encourage the young generation, the parents, right, as well as our seniors. So thank you so much for that. But I feel good with my future being in your hands, Kayla. Adolescents, what would you say to that?
I would say that youth are definitely going to make a huge progress and a huge leap in dispelling mental health stigma. I do want to make a point, however, that a lot of people say youth are going to be the ones to like really bring forth the mental health field and challenge everyone's perspectives. But at the same time, I think that everyone, including adults, should be proactive and not put that much pressure on the youth. It is not entirely the youth's responsibility to break traumas and break cycles and educate their elders and adults about what's going on. And I think we as people and adults and young adults should constantly have those conversations, constantly reflect and challenge our notions and our biases and what we were taught growing up. And I think only then, when it is a collaborative effort between youth and older generations, will we be actually able to completely rid of mental health stigma. But I am hopeful for youth. I do think that they're going to make a lot of progress, but the only way they will be able to do that is if we offer them the power, if we offer them seats at the table, if we are right next to them, helping be that guiding force for them.
I love that. That's so important. It truly is a collective effort, right? Like, you know, we get together and we lock arms in this mental health effort. There is power in numbers. And so you've heard it from our youth today. We have to do this together. This is not a or them or us, right? It is something that we have to collectively come together and continue pushing this narrative forward as we continue to erase stigma. That's why these sort of conferences are so important. That's why the work that the Carter Center does, the work that we do at Silence to Shame and all these other incredible organizations on here today is so vitally important. Any final words, Kayla, or if you want to leave us with ways to reach out to you, you don't necessarily have to share your social media information, but any parting words? Kayla?
I think one thing is, again, giving that power and agency back to youth. I think, Adolescent, that was a great point, saying that we shouldn't leave all the responsibility on the youth, because that is not fair. And we do need to engage older generations or even younger generations before us that in these conversations. It really is a collective effort. And I think, especially even when talking about like data collection, for me, I'm a very logical person. So like these statistics that are provided in the report or through the CDC are so powerful, but we can really stand to benefit from more qualitative data collected from youth themselves in interviews. So I think the statistics really can be very jarring and capture that surface level or like a snapshot of it, but that qualitative data in which youth are involved, are help guiding, can really offer better insight. And I think that's really important when we're thinking about building interventions or ways to really tackle the root of this problem. So I think really power to the youth and adolescents.
Thank you. Any final words, Adalise?
I just want to thank you for being our moderator and being so engaging and lovely with Kayla and I. We're really appreciative of all your work with Silence the Shame and being here with us today. And I also want to thank everyone who's in this like virtual room today, starting the conversations and actively listening. That's a first step. I'm not sure if it is your first step ever, but it's always good to constantly be engaging in these conversations. And so, yeah, I think a huge takeaway is listening to youth, engaging with them, learning about culturally competent mental health care is, I think, one of my most passionate topics, and really creating a strategic plan as a whole unit.
Thank you, and thank you. You have been tuned in to Youth Voice, Framing Mental Health. I am again your moderator, CEO and founder of Silence to Shame, Shanti Das. You can follow us at Silence to Shame on Instagram, and our website is www.silencetoshame.com. Again, we heard being human, being kind, not judging, being involved, a collective effort, doing this together. We all have mental health. We may not all have a mental illness, but we can support our communities together, and we are stronger together. Remember to take time, save a life, and silence the shame. Thank you, and good afternoon.
Thank you so much, Shanti, Adalise, and Kayla. What a great discussion. Really appreciate it. And I just want to reiterate, yes, save a life. This is a call to action. It's a community effort, and hope you'll take a picture or a screenshot and be reminded of what came out of the poll and the questions that you were asked today. I also want to thank the audience. We hope you enjoyed day one of the Rosalynn Carter Georgia Mental Health Forum. I hope you found it a good use of your time and that you plan to be back with us tomorrow for some very active and engaging additional panels. Please don't forget that you do need to register separately for tomorrow's panels. We'll drop the registration link again in the chat. And also, please don't forget to post with hashtag Georgia Mental Health on your social media. This can be the positive impact of social media, as Adalise laid out in her comments. Thank you again, Shanti. Thank you, Adalise and Kayla. So great to be with you guys. Have a good day. Thank you.
Bye, everyone. Thank you so much for having us.
Bye, everyone.